Our first speaker is going to be Dr. Jennifer Barr, and she is an associate professor with the Department of Psychiatry with a cross appointment with the Department of Respirology. And she's the physician lead of the London Health Sciences Center Consultation Liaison Psychiatry Service. And she divides her time between consultation with the liaison psychiatry and sleep medicine. And she's going to be giving us a presentation and an overview of sleep disorders prevalent in patients with developmental disabilities. So please welcome Dr. Barr.
Good afternoon. I don't have any conflicts of interest to disclose. Just trying to figure out where to look. The objectives you have, by the end of this presentation, I'm hoping that you will have a better ability to identify the sleep disorders that are prevalent in patients with developmental disabilities, have a little bit of an approach to begin to assess and begin management in this patient population as well. And then I think a good take home is to know when to be referring into a sleep clinic. So the outline, I'm going to have a brief introduction. The 4 sleep disorders that I'm going to really briefly outline for you because we have a short amount of time. Insomnia disorder, the circadian rhythm sleep-wake disorder, one specific one called phase delay. The breathing-related sleep disorders, we're just going to cover obstructive sleep apnea, restless leg syndrome, and then I pull it all together in terms of assessment and management. Sleep is crucial to life. It's one of our basic homeostatic drives. We spend a third of our life sleeping, and it is crucial to our overall well-being, how we grow, how our brain develops, our overall health, learning, memory consolidation. We know that patients with developmental disabilities have significantly higher rates of sleep disturbances. And I just sort of doing my own lit search on the topic for you guys, pulling out some of these numbers. I was quite shocked myself. Remember, I'm coming from the general adult population. So when I got reading into this, I was pretty surprised. So up to 40 to 80% of patients with developmental disabilities are going to have some sort of disruption in their nighttime sleep. Up to 93% in patients with autism, compared to 3 to 36% of the typically developing child and adolescent population. So the sleep disorders are under-recognized, they're not picked up, and from my reading are often not even screened for. And the impact here is really significant in this patient population. Behavior will be impacted. There's increased rates of agitation, outbursts, emotional dysregulation, increasing repetitive behaviors. Cognition and learning will be negatively impacted. Overall mental health, increased depression rates in patients that aren't sleeping well. And then a big one that I read about was the caregiver burden of this. Because if there is a patient up at night not sleeping, likely there's a caregiver also up at night not sleeping. That's going to impact their ability to function, to keep structure and routine in the household. It will interfere negatively in relationships within that household. It will affect the sleep of the siblings. Another thing that came up is the medication escalation. So in a patient with a developmental disability and a sleep disruption, they're often presenting to you with worsening of behaviors, okay? And if medications are now prescribed to treat those behaviors, these medications might be a part of the sleep problem at night, when really, if we can fix the nighttime sleep, we're going to be able to get away with a lot less in the way of medications, potentially. Why are the sleep disorders more prevalent in this patient population? There are certainly biological factors. There could be some changes in the circadian rhythm genes. There are some difference in neurotransmitter production and release. Medical comorbidities, this patient population may have higher levels of pain, epilepsy, seizures, heartburn, GERD, other medical factors that could be impacting sleep. Behavioral factors, maybe not having structure and routine in the day-to-day, maybe not being able to self-soothe, emotionally regulate, especially around bedtime and evening. Maybe also not being able to appreciate or understand the social cues as related to getting ready for bed and nighttime. And then environmental factors, this patient population may have more sensory needs, okay, or be more sensitive to whether it's noise, sound, sheets, sensations. So that's a little bit of a background, and now we're going to jump into those 4 sleep disorders. And again, it's going to be, with our limited time, a superficial, just an overview of these disorders. So insomnia disorders, most prevalent of sleep disorders. DSM-5-TR, so this is when a person has difficulties getting to sleep, staying asleep, or early morning awakenings, happening at least 3 days a week for 3 months, impairing function, not primarily due to a medication, substance use, or medical disorder. Insomnia is a cognitive and behavioral disorder. This is not a disorder about neurotransmitters in the general population, okay? This is something goes wrong with a person's sleep, they become preoccupied with sleep, their inability to sleep. The more they try to sleep, the less they're able to sleep, and you end up in this vicious cycle. Wakefulness is in the bed with high anxiety, high stress, and with time, this leads to a conditioned cognitive arousal. People may be sleepy, but they get into bed, brains on. Wake up in the middle of the night, brains on. A conditioned cognitive arousal with maladaptive sleep behaviors, trying to correct it by maybe sleeping in later, taking naps, spending excessive time in bed trying to get the right amount of sleep. A little bit about the epidemiology, very prevalent. So insomnia complaints in the general population, 30 to 45%. And I think for the family doctors here, I understand that it's one of a leading presentation to clinics can be sleep disruption. But if we look strictly at the DSM-5 criteria, about 6 to 10% of the general population, up to 25% of elderly. And again, finding up to in the developmental disability population with the child and adolescents in particular, up to 75% as compared to that 3 to 36% in typically developing patients. The assessment here and the diagnosis is clinical for insomnia, right? We don't need a sleep lab. It's looking at sleep diaries. You need a sleep history. You need to understand the behaviors around sleep, the timing of sleep. Sleep diary. My suggestion would be if anyone ever comes to you with the complaint of I can't sleep, get them completing 2 weeks of diaries, then see them because so much information is in there. And I'll talk about that a little bit later in terms of picking out clues for phase delay. The management of insomnia is cognitive behavioral therapy for insomnia. It is the first line treatment. It is really the only cure of the disorder because as I spoke to you, this is a disorder of cognitions and behaviors. So when you change that, you get a person back to their baseline sleep. Unfortunately, I do not have the time today to get through the individual components for you. So there's a reference here that you can look at, trying to find some of the behavioral strategies for patients with developmental disabilities. What can we do to enhance sleep? Adjusting the sleep environment. Is this environment quiet? Is it dark? Is it not too stimulating? Ensuring that the bedroom environment is not a place for discipline or negative consequences, trying to keep it a positive space. Making sure there's no electronics in that space, making sure electronics are out of the space at nighttime, and trying to minimize the amount of time spent in that space, particularly in the bed. Evening routines, having a clear, structured routine each evening as part of getting ready for bed. You know that in your patient population, transitions can be very difficult. So you want to have, if a kid is on an iPad right until bedtime and you say, okay, time to go to bed, it's not going to work out well. So you want to have that tech off probably 1 or 2 hours before the bedtime, have a long, pleasant, drawn-out transition into bed, using visual aids of the steps potentially, depending on your patient population, reward systems with stickers as steps are achieved. Light exposure, obviously the environment being dark in the evening, but bright light in the morning can be helpful. Getting outside, getting bright light, or using even a light box if that can be tolerated. For the patients having difficulties getting to sleep, for sure avoiding naps, especially in the last half of the day. Bedtime fading is a strategy where the bedtime is moved to within 30 minutes of the patient's natural falling asleep time. Okay, so now they're staying up later, going to bed closer to when they naturally fall asleep so they can build up some independence and confidence in their ability to sleep and then gradually moving that bedtime earlier, okay? Graduated extinction is another behavioral technique where the patient will be in bed, cry it out for a discrete amount of time. So you start maybe with 2 minutes, caregiver comes in, does a brief acknowledgement, doesn't touch, you're okay, it's going to be okay, leaves, but gradually builds out that time in between. This will help promote some self-soothing abilities. And with the nocturnal awakening, similar, some patients you'll find out when you delve in, they can only get back to sleep if they've got the parent there massaging them or doing something like this. So what you want to do is kind of take the physical piece out and have the parent more robotic at the bedside, not engaging, and sort of gradually move the parent out of the bed. Sleep-wake scheduling is very important. The most important aspect is a consistent wake-up, okay? It's the wake-up that sets our homeostatic drives. So to get regularity in our sleep-wake cycle, it's about a consistent wake-up time. Okay, because I know people are going to ask, what do we use for sleeping pills? Because that's what happens. So the pharmacology of insomnia, I have to cover it, even though I would choose not to. In general, this is for the adult population. Hypnotics are indicated short-term at acute situational stressors. They are not indicated for chronic insomnia. In fact, they make insomnia worse in the long run. The reason being, I go back to right at the beginning where I told you insomnia is not because we're missing a neurotransmitter and we've got to replace it. No, it is about behaviors and habits. So you prescribe that sleeping pill, now they sleep. Aha, I knew it. I need that thing to sleep. I'm not capable of sleep. With time, it builds and builds, and they just believe they're not capable of sleep, but every person is capable of sleep. It's a basic homeostatic drive. It's the mind, it's the behaviors, that's what's in the way of it. So the medications kind of encourage this helplessness with the problem. And what I see by the time I'm seeing patients is it's a psychological dependence, right? People believe they need this medication. Now, in the developmental disability population, it is a little bit different. I'll come to that in 2 slides. So here's kind of the list of different medications I could think of that maybe would be prescribed to help somebody sleep. The red underlined are the only ones that are Health Canada indicated for the treatment of insomnia and that are indicated through the American Academy of Sleep Medicine as treatment options. Just note Ramelteon we don't have in Canada. The only practice guidelines I could find in the developmental disability population were the American Academy of Neurology guidelines published in 2020 for children with autism spectrum disorder. And just a summary of these guidelines in general. First of all, assessing for medications, underlying medical conditions, making sure those are treated. Counseling patients and the caregivers about the importance of sleep and some of those behavioral strategies that I was mentioning. If those interventions don't help, then melatonin. The research that was summarized in the guidelines looked at doses of melatonin between 2 and 10 milligrams given 30 to 60 minutes before sleep. Keep in mind, the duration of all these studies, 12 weeks, right? So they're not long-term studies to see what's happening. Are we developing tolerance to that or not? In autism and ADHD, melatonin is a bit different than in the general population. It is not released probably at quite the same level, and there's a delay in its release. So it does make sense to me. Here we are talking about a bit of a neurochemical change, right? So it does make sense that we're using a very low dose of it, possibly before bedtime. I wouldn't know why we'd be using 12 milligrams, 15 milligrams, 10 milligrams, but maybe a little bit. Then there's the question of weighted blankets. So the research on weighted blankets don't show necessarily a positive effect, but there's not a negative effect, okay? So no adverse outcomes with the use of weighted blankets. That was a quick one on insomnia, so we'll go now over to the breathing-related sleep disorders. There are a few breathing-related sleep disorders. I'm just going to speak about obstructive sleep apnea, hypopnea, as it's the most prevalent. Am I in your way? I just realized I might be in the way of the screen there. Okay, so the DSM-5 criteria here, this is on evidence of polysomnogram, PSG, that there's at least 5 obstructive events per hour in addition to either nighttime breathing symptoms or daytime symptoms, or we have at least 15 obstructive events per hour, okay? So that's kind of the diagnosis. You need the sleep lab to make the diagnosis here. So this disorder is about repeated apneas and hypopneas due to obstruction in the upper airway, which you can kind of see here. Essentially, in sleep, the upper airway is narrowing, closing off, reducing airflow, all right? And that reduction in airflow causes the brain to have a micro-awakening to get breathing again. So when people are staying with us overnight in the sleep lab, we're looking at that entire process. How many times does it happen? So they have to obstruct and then have an arousal to get breathing again. And we look at how many times an hour that happens. So the clinical features on this one, daytime sleepiness in the adult population is the most common symptom. I do find that women more often present with fatigue than sleepiness. So I don't want you just sending your patients in based off the Epworth sleepiness scale, okay? Looking at other factors as well. Snoring, a dull frontal pressure headache for the first couple hours of the day. In your patient population, this might actually present with morning irritability and agitation more so than anything else. Dry mouth, peeing more at night, heartburn in the middle of the night, and then behavioral disturbance. So this is the one again for you guys that it may not be sort of some of these classic, it could be a change in behavior, right? Restless sleep. So just again, looking at the epidemiology here, in that first point is in the general population. So maybe 1 to 2% of children, usually due to adenotonsillar hypertrophy, 2 to 15% of middle age, greater than 20% of older adults. But look at these numbers in a few of the disorders that I pulled out. Down syndrome, 50 to 80% of patients will have apnea. Prader-Willi, up to 89%, and in that are central sleep apneas as well. So I would say with this one, the threshold to refer into a sleep clinic for an overnight PSG is very low, right? Just looking at some of the rates in some of these populations. So the assessment is the lab, using our lab to make the diagnosis, and management strategies will always be losing weight can help. Often the apnea is very positional, just on the back, but we can see that and we'll make recommendations about sleeping off of the back or not. The mainstay of treatment is positive airway pressure, so sleeping with the mask connected to a little machine at the bedside that pressurizes environmental air. That air comes in and splints open the airway, physically holds the airway open. Mandibular advancement devices are seeing specialized dentists to get an appliance made that springs forward the jaw to pull open the airway in the middle of the night. Keep in mind that certain medications, narcotics, benzodiazepines, alcohol can all exacerbate the problem. Okay, the circadian rhythm, sleep-wake disorders. Circadian rhythm. I started chopping slides when I found out how slow this was, so I didn't get into the regulation of sleep. But one of the factors, 2 factors, sleep homeostasis, the drive of us to sleep is one factor. The other is the circadian rhythm. Our entire body brain is on a 24-hour cycle. When we sleep, when we wake, when we sense hunger, hormone secretions, body temperature variation, all on this background 24-hour cycle. The timing of the cycle is coordinated by light. When it's light outside, we're awake. When it's dark, we're asleep. The circadian rhythm. So the circadian rhythm sleep-wake disorders, there's a number of them. These are disorders when there's a sleep disruption due to an alteration in that underlying circadian rhythm, or there's a mismatch of our underlying circadian rhythm and what's required of our environment. And this disruption leads to either insomnia at night, sleepiness during the daytime. So there's a number of these disorders. The most prevalent, and the one here that I need to highlight for you guys, is the delayed phase type. I am going to spend a few minutes here because it's important. So the delayed phase circadian rhythm, the entire 24-hour cycle is still happening, but it is shifted. So now the person cannot fall asleep at the desired time and they cannot wake up at the desired time. So they are just not able to sleep before 1, 2, 3 in the morning. The natural time to wake up might be 10 or 11 in the morning. So these people do not present to you with a circadian rhythm phase delay. They present to you with, I have insomnia, I can't fall asleep. The caregiver is presenting to you saying they've got insomnia, they can't fall asleep, okay? The whole pattern is shifted. And what we know with ADHD in particular is that there is change in how melatonin secreted. It is delayed, that secretion. It's not quite as high, and there's elevated levels during the daytime. But just look at these prevalence rates here, and this is so important. In ADHD, 73 to 78% of patients have a phase delay. So when I get a referral into the sleep clinic for insomnia, and I see a history of ADHD, they're triaged right over to phase delay, because I know they're phase delayed. They don't have insomnia, okay? It's tricky, because here's what's happened. They present to you, I can't sleep, the sleeping pill's prescribed. Now what happens, let's say they're trying to sleep at 10. Natural time to sleep maybe is not till 2. Trying to sleep at 10, so the hypnotic's prescribed is up, till finally they fall asleep around 10. Then they sleep for a few hours, then they're wide awake because they've just had a chemically induced late night nap, right? So if any of you fall asleep at, I don't know what time, I won't put anyone on the spot, but I fall asleep at 11 at night, okay? Or something like that. If you gave me a whole bunch of hypnotic medication at 7 or 8 at night and knocked me out for 3 to 4 hours, guess what? I'm waking up at midnight and I'm wide awake now for the rest of the night, not going back to sleep. I can't tell you how often this disorder is missed. It's so prevalent. If anything of my take home here is going to be someone presents to you not sleeping, it is phase delay until ruled out, especially if it's ADHD. So how do we figure out the phase delay? Can be tricky. Sleep diaries are, again, really helpful. So let's say you get that 2 week of sleep diaries and you see that this patient can't fall asleep, right? They're up to like 1 or 2 in the morning. They've got to get up at 7 for school. But then all of a sudden on weekends, they're up later, but they're sleeping till 10 or 11, right? That could be a clue, right? That they're sleeping in later. The morningness and evening questionnaire, you can take note of that and look that up. That is a multiple choice. So basically you get a scenario of, in your ideal world, and it might be hard in some of your patients, but maybe caregivers might be aware of this. In your ideal world, when would you fall asleep if you had no, didn't have to get up? And you're given options of choices of when that would be. And you can get a sense of whether or not they're a morning person or evening person. So that could be a scale. Circadian rhythm phase delay is pretty easy to treat, actually, okay? So how do we treat it? We use 0.5, when I would, in a pediatric population, use 0.5 milligrams 4 to 6 hours before the ideal sleep time. So it is not a hypnotic medication, it is a circadian rhythm modulator. So basically you're getting that nocturnal surge of melatonin, which physiologically is about 0.5 milligrams for most of us, by the way, at evening, that peak. So you're giving that surge in the late afternoon, early evening, and it tricks the brain and it shifts that entire rhythm forward. Combined with bright light in the morning, using a light box in the morning, sleep-wake scheduling is also very important because if you continue to sleep in till 10 or 11, you're not going to fall asleep till 2 or 3 in the morning. So you also have to have the person consistently getting out of bed earlier and avoiding naps, okay? Restless legs. So restless leg syndrome for DSM-5, an urge to move the legs, usually accompanied by an unpleasant sensation. The urge to move begins or worsens during periods of rest and inactivity. The sensations are partially or fully relieved by movement. The urge to move the legs is worse in the evening, happening at least 3 days a week for 3 months. So it might be hard for your patient population to verbalize this potentially, and I find that even in my adult population, people don't come to me saying I have restless legs. Instead, they come to me again with insomnia. I can't fall asleep. I'm just physically uncomfortable. I got to keep moving and changing. So what it could look like for your patients is maybe they're wiggling around. You're asking the caregiver, they're moving a lot in bed. They're physically moving when it's bedtime. They're pacing in the evening, maybe slapping their legs on the pillow, the bed, mattress, rubbing them together. more agitation around the evening, because usually that's when the sensations come on, is in the evening. So if you're seeing kind of an increase in agitation in the evening, possibly something to think about. This will lead to sleep disruption and inability to fall asleep. Potentially, even a person could wake up in the middle of the night and have the symptoms also. They could be sleepy during the daytime, and again, behavioral changes, right? Behavioral changes. So restless legs can be completely idiopathic, tends to be genetic. For the patients that it's idiopathic, it's an earlier onset, associated with a number of medical conditions as well, the most common being low ferritin stores. And then I've actually added in ADHD and autism just because rates are high in these patient populations. But let's just take a second here to look at this last point about being associated with substances and medications. Caffeine, nicotine, alcohol, precipitators of restless legs. Just about all of the antidepressants, all of the antipsychotics, the antihistamines, even melatonin, okay, can cause this. So let's say a patient is not sleeping well at night. There's behavioral changes during the daytime. We start treating the behavioral changes with antipsychotics. We are going to make the legs worse, and we end up in this vicious cycle and spiral. Or maybe we're upping melatonin. This is making the legs worse, and you're in this negative spiral. Okay, so another important one to think about. So in terms of epidemiology, 2 to 7% of the general population, definitely as the population ages, the disorder becomes more prevalent. But up to half of all patients with ADHD will have some degree of restless legs. I went and looked into that a little bit more. Probably they tend to run lower on their ferritin. Okay, so we're going to also highlight ferritin as being an important thing to check and think about anytime we have any sort of sleep disruption or, again, behavioral change during the daytime. The assessment here, the diagnosis is clinical, right? It's just clinical based off these symptoms. We don't have a lab test. Management. We always start non-pharmacological, although I've put IV iron here. I suppose that's technically pharmacological, but we're trying to get iron up. In restless legs, we're looking for 100 micrograms per liter, okay? So you know if you order ferritin, it's coming back 30, it's normal, but we would still be iron replacing to get up higher. Some people do not tolerate the oral. We can't get it up as high as we'd like. This is where the IV iron becomes important, and I'm trying to figure out how to do this because it is sort of our first step in the treatment guidelines now for restless legs. I think you guys know for the GPs, I don't think that you can refer in to hematology to get the IV iron. They're accepting some from me right now, but I've just had one deny me as well. So it's actually a pretty hard thing to track down. So we want to look at the overall medication list for a patient with restless legs. What can we potentially change, reduce to improve this? Often we need certain medications like the antipsychotics for behavioral management, or we might need the antidepressants for mood. I find that even if we can get the SSRIs into the morning, that sometimes helps. Alcohol, nicotine, caffeine, minimizing, reducing these. Apnea. Apnea is actually a precipitator of restless legs. I find so many patients, we treat that apnea, they're asymptomatic with their restless legs. Strengthening nighttime sleep, because the more fatigued and exhausted somebody is, the more they're feeling their restless legs. So when we strengthen nighttime sleep, they tend to do better. Hot, cold compresses can help, hot baths or showers before bedtime. Maybe that can be built into the bedtime routine. Pharmacological. Now, this has really changed in the last 5 years. The American Academy of Sleep Medicine published treatment guidelines in September of 2024 for restless legs. The first line now is the alpha-2 delta ligands, okay, so gabapentin and pregabalin. And in fact, we should not be prescribing the dopamine agonists. They were first-line treatment for a couple of decades, but because of the risk of augmentation and worsening restless legs, they should not be prescribed anymore. And then the IV iron. Okay, we're doing really well with time, so we'll have lots of time to chat. Okay, so let's just sort of pull it all together into sort of some general assessment and management approaches. Given the prevalence of sleep disorders in your patient population and the significant impact on their daytime functioning, I do think screening for sleep should be a part of any routine health check-ins. And that would be looking at the routines around bedtime, the timing of sleep, how they're sleeping, if they're up in the middle of the night, full medication reviews, screening for the medical contributors, getting the sleep diary. Stop Bang is a nice screener for apnea. However, it's validated in a general adult population, right? Not in your patient population. And as I said, in your patient population, that threshold to think apnea needs to be low and referring in for a sleep study. The ESS is the Epworth Sleepiness Scale score. So this is how sleepy somebody is during the daytime. And then the MEQ is just that morningness and eveningness questionnaire that I encourage you to take a peek at. All right, here we go. This is for you guys now. Okay, so what sleep disorders are we gonna think about in your patient who's having difficulties getting to sleep? What do we kind of have to rule out or think about? Getting to sleep. Restless legs, yes. Delayed phase, especially if there's ADHD, it is phase delay until ruled out, right? Yeah, and then insomnia. Like the behavioral piece, right? Okay, the patient who's not maintaining sleep, the problem is about awakenings in the night. What should we be thinking about? Yeah, apnea. Yeah, restless legs again. And then insomnia, right? The insomnia of maintaining sleep. And what about in the person presenting with sleepiness? Yes. Restless legs, insomnia, phase delay, all of them, yeah. Okay. We have a patient with Down syndrome experiencing a change in behavior. What do we have to think about right away? Sleep apnea. Sleep study, right? Referring in for a sleep study. Patient with ADHD having difficulties initiating sleep. Phase, yeah. A patient with autism refusing the bed, not wanting to go to bed at night. Yep, insomnia, the restless legs. Yeah, good. So the general management overview is take care of any potential medical or medication contributors. Always start with the education piece and that behavioral piece, because when we can actually get behavioral strategies implemented, you are going to require a lot less in the way of medications for daytime symptoms and nighttime sleep. Last line really is medications. When to refer to the sleep clinic, any suspicion of a breathing-related sleep disorder. Daytime sleepiness, especially if they're sleeping well at night, I would still be sending them in. Any of the parasomnias, we didn't cover this. Parasomnias are abnormal behaviors as related to different stages of sleep. So this might be sleepwalking, acting out dreams. And then if you've started treatment with insomnia, phase delay, restless legs, and your patient isn't responding, that would also be another good reason to send in. So the take home, when behaviors are worsening in your patients, first think sleep, check sleep, screen for sleep. Education and behavioral strategies are first line. Before prescribing any medications to help with sleep, please think about, have I ruled out apnea, restless legs, a phase delay? Check and optimize ferritin. Ferritin. It tends to run low, as I mentioned, with ADHD and in autism as well. Okay, so then trying to find some resources for you folks, and I think if you take a picture of this screen, or maybe they can email it out. The Canadian Pediatric Society, I found, had a nice position statement about supporting healthy sleep for children and youth with neurodevelopmental disabilities. And then these were a couple of the better review articles that I looked at in preparation. I'll leave that there for a sec. And then for the Patients Aid Canada, I don't know if this is a website that you guys use often or not, but there are, when you go in there and search for sleep, there's some really nice videos for kids, cartoon related, about promoting nighttime sleep for parents. And then this handout I found was quite good as well. I thought it was a really nice handout that you could have hold it or make a version of to hand out to families. All right, good. That's all I have. Now we can chat.
Do you have any questions for Dr. Barr?
So in your experience and in your lit review, what's the role of screens for this population and sleep? Yeah, screens and sleep.
So the screens need to be out of bedrooms 100% at night, everything plugged in, charged somewhere else. For sure, 1 hour before ideal sleep time, there should be no screens, maybe even longer, because remember, this is a patient population that struggles with transitions and changes, and often screens are used for reward and something. And if that's there and suddenly take it away, go to bed, it's not going to work out. So they need to be out and done at least 1 to 2 hours before.
Is there any considerations around age for the delayed sleep phase? Because I always thought of it a little bit more as into adolescent and developmentally.
Yeah. Yeah, that specifically for the ages, I don't know. I did look up and see that our melatonin secretion patterns are 3 to 6 months established. So I'm thinking that that's probably abnormal right from the beginning, I'm thinking. But you're right, the peak onset in the general population is adolescents. I don't know in the developmental disabilities. And the rates I looked at, the research I found had said child and adolescent, right? So I would be thinking about it right away, but you're right. I think it's going to become more prominent into those teenage years.
And my follow-up to that is, can it still be delayed sleep phase of the child? I'm thinking younger kids, like elementary, if they're not sleeping in. Like they go to sleep late, and there seems to be consistency around there. But
your big clue is going to be that they would be sleeping in when they don't need to get up for school, right? That there would be a later sleep in. It's different because the sleep needs are also really different, right? Like depending on what age of population we're talking about.
I had a quick question, a practical one. What percentage of individuals, like in terms of doing a sleep study in this population, like they got behaviors and have a difficulty, how much time do you need to get them into the lab to make a reasonable assessment?
So for your patients, it's going to be the child and adolescent lab, and I should have looked, that would have been a good thing to look into what their wait time is right now if you refer in. I can tell you us, for 18 and older, it's 10 to 11 months before we get this study.
What about the role of oximetry? I find that useful in the adult population to screen and then gives you a better indication.
This is a good point. So you can get a home sleep test. So London Home Respiratory on Springbank will give these out. They cost $50. It has a pulse oximetry as well as nasal airflow. So you're looking at the DSAT. So this can be a really good screener. The issue is, let's say we pick up a whole bunch of DSATs. We know there's apnea there. We cannot get the assisted device coverage on a CPAP unit unless it's been an in-lab study. So it is a good point. You could screen that way. If a family had $50 through...
And they're in my building, so they'll sometimes with circumstances they'll waive a fee.
They might even waive it, yeah.
And,
I think they're really good actually, and I've actually seen that happen as well. So it will let us know about DSATs and some obstructive events for sure. At least it's a screener, because if that's normal, you know that you don't have that and you don't need to wait the 11 months.
What about the self-adjusting CPAPs? Like if they're high risk and you can't get them into a lab, like some families might be prepared to...
Then they would be paying privately, right? Yeah. And that's going to be $1,500 probably to $2,000. And the question then is, what's the pressure needed? And like you're saying, an APAP, an auto-PAP, where the machine has a pressure range and actually figures out the pressure needed to hold the airway open, could be a potential. The issue is then they get into us, and I've had this happen. I'm not connected to that machine, but usually a vendor can help sort that out so that I can look at the data and see what's happening. Okay. But that's a good practical tip, especially if a family has a couple of grand and you've done that home study that shows there's significant DSATs. One thing to keep in mind though with APAP, if there's a lot of central apneas, APAP can actually exacerbate those. Don't ask me the physiology on that. But I'm just thinking about was it Prader-Willi that I said that had the high central apnea rates as well. So I probably wouldn't want to do that in that patient population.
Dr. Goldberg.
It was an excellent pediatric neurological summary of sleep disturbance. I would just add one other factor in terms of assessing a sleep disturbance, and that's the psychosocial aspects.
Yep.
What are the sleep patterns of the parents?
Yep.
What's their anxiety?
Yep.
What's their pattern of
Yes.
going to sleep?
Yes.
So that's the advantage of having a social worker assessing.
Yeah, and it is important because, right, like if there's not a match within the family or the sleep timing required of the family, and then also that disruption to the caregiver's sleep does lead to irregularities in daytime routines and rhythms, and this spirals the whole piece behaviorally.
Thanks. I have maybe a different perspective because I don't see a lot of young kids, but I do see a lot of adults with developmental disabilities.
Me too.
And I fully appreciate the importance of doing everything you can before you get to a pharmacologic strategy. But we have parents who are like tearing their hair out with kids who like don't sleep for 24 hours at a time. If you have to choose something to maintain sanity in the home, what do you choose?
Yeah, and that's usually what happens, right? And again, you guys know I don't practice in this population, but that is what I understand happens. You've got a family showing up in crisis, and you try and teach them everything you can about behavioral strategies, change routines. Even if they can do that behaviorally, like the fated bedtime extinction, this is kind of like months, right, of work to get there. So I think that's where the medications are needed, but you have to be thinking about the rest of it, and you have to be also mindful that you're not going to make what's happening worse, right? Like you're giving melatonin now and it's exacerbating the restless legs, right? Or you're giving Remeron or olanzapine or something like this, it's exacerbating the restless legs. So we have to kind of just sort of be sure of some of those pieces, which I think is pretty easy to do. And then keeping your dose as low as possible. And in conjunction with that prescribing, there should really be the importance of that behavioral piece there. There's no long-term data in your population. The studies are all about 12 weeks, okay? So if you look at the adult population, with any hypnotic, there is a sedative effect initially, but that tolerance develops and they are not working within, a few months. So I'm not sure if that's the same with melatonin. I suspect it is in your patient population as well. So this is why you want to go in with that really low dose and be working with them to implement the behavioral strategies.
Thanks, Jennifer. So
Yeah.
is there no dose correlation with melatonin that you're saying 0.5 to 1 is all you would suggest?
0.5 to 1 in phase delay, okay? Because in phase delay, we actually just need, and I would say in the pediatric population, 0.5, because that's our physiological surge. This is just what we're trying to trick the brain to pull it forward. You don't want a higher dose, because if you give a higher dose, now they're gonna get sedated after that 5 o'clock dose, and now they're gonna nap, and you've just undone everything. So you want 0.5, I would say, in a pediatric, and not higher as a circadian rhythm modulator. Now, when you start talking about the hypnotic piece, that's different, right? And by the way, the American Academy of Sleep Medicine for the adult population advises against the use of melatonin for sleep.
One other question.
Yeah.
So after going through the whole process of getting the sleep study done and the CPAP machine done, parents came back upset that the sleep doctor said, if you're getting 3 to 4 hours of sleep, that's what you...
Well, I'm going to tell you that a lot of sleep doctors in this region are respirologists, okay? They're not coming from that full behavioral perspective. So I'm sorry if that's been the experience, but that shouldn't be the experience, right? Sleep is holistic. It is not just apnea. You have to look at the behaviors. You have to be optimizing the ideal amount of sleep and timing of sleep, right? But unfortunately, sleep medicine is very driven by respirology, and there's a apnea focus, right?
Thank you.
Just a quick comment with the weight, with Down syndrome and Prader-Willi. We're getting into some of the newer medications like Ozempic and Mounjaro that are very helpful.
Yes, exactly. And so that's sort of up and coming research and studies are being in the adult population as well, right? Is looking at this as a treatment for apnea, is that weight reduction. Yeah.
We have a question over here.
Two-part, if I can take that much time. In restless leg syndrome, any concern about magnesium or zinc or any other?
Yeah, okay. So good questions. We do not have the randomized controlled trials looking at magnesium, but there's certainly enough anecdotal evidence and people will say, I have so many patients come to me and they're on magnesium and they feel much better with their restless legs. So we do not have the randomized controlled trials. That's why they're not in our treatment guidelines. Sometimes I will suggest it to people as an off-label just because I've had so many people come to me with improvements. Yeah.
And then other than in restless leg, any other role when we're considering sleep for optimizing ferritin?
Any other, or how it might be helpful, or?
Yeah, because you were talking about, and make sure, that you
Yes.
optimize ferritin. Is that only restless leg? Or
Okay,
could it
so
be
yeah,
any
so
other?
in restless legs, you want to get that ferritin high, right? 75 to 100 micrograms per liter. In general, though, if you're just looking at a patient, you just want to be within the normal limits, right? Because I think that in general is going to help energy levels, how a person feels during the daytime.
Now, of course, there's normal, there's possible iron deficiency.
That's right.
Probable
That's
iron
right. And it's all just recently changed, right?
When you're
So
saying normal, you mean normal as in above the possible iron deficiency?
yeah, yeah. Because I think that's going to optimize how you feel during the daytime, right? I mean, well,
You can feel the cold, your hair might be thinner and stuff like that.
Oh, sure, but how people are addressing the possible and probable iron deficiency seems very variable amongst different practitioners. So I'm
Correct.
trying to figure out this confusing new situation.
yes, I guess it would depend on whether or not there were any sorts of symptoms, right? Like I think if someone is running at 20 or whatever the possible number is and they're completely asymptomatic and fine, I suppose practitioners might not fuss too much about
And
it.
if they're fatigued, that could be a possible contributor. Thank you.
Yeah.
Another question. Oh,
Jennifer, thanks. That was fantastic. Actually, it was really wonderful. But just two quick questions. So just to follow up on Greg's question about the sleep lab and the weight.
Yes.
I just wonder in a lot of the kids leagues, and I would say this, children generally, but perhaps more in the developmental population, how, from what you know, and I realize you don't work with kids directly, but how many of them can tolerate falling asleep in a sleep lab? Because I would just wonder if you'll have sleep problems anyway, and they're in an unusual environment with wires all over them.
Totally. And so that's in my adult population too. I have people that fail, especially if they are more anxious or have disrupted sleep. So I do think it's something to think about. I will tell you that I occasionally prescribe a sleeping pill. Someone begs me and it's the only reason I can. I'll give them a sleeping pill that night to try to help. Remember, the caregivers can stay overnight too. So that does help. And usually the labs are pretty flexible. So for example, like with my phase delayed patients and I want to look for apnea, I'll ask the lab, is there any way, instead of starting the typical studies, checking at 8 and starts at 10 and is done by 6, I'll say, can we change staffing for this person to sleep at like a 1 to 9 so we get the best chance? And our lab is really flexible that way. So if there is something, or if they need screens or they need self-soothing or whatever, I just find our lab is very flexible with that and the timing to try to optimize. And remember, for apnea, we don't need a perfect night's sleep, right? Like we kind of know if it's going to be big in there, we're going to know within a few hours, right, of sleep. So
The second question was around ADHD and phase delay.
yes.
How would stimulants affect that?
Yep. So interesting with the stimulants. So absolutely, if someone is taking a stimulant late in the day, anybody, you're going to potentially be up later, right? So we want to keep the stimulants earlier. But what's interesting is, I think a natural thought is not sleeping, got to reduce stimulants. But I actually found some early research that, in fact, undertreating the ADHD will worsen the nighttime sleep just because there's more hyperactivity, right? So you actually do want that treatment there. But that phase delay is independent of the stimulants, because some people might think, it's because there's a stimulant, they're just up later. No, right? If we took that away and we measured saliva, melatonin, and staging, you would see that delay whether or not you had your stimulant there.
But every now and then we see parents who swear their kids were fine sleepers before stimulants.
Yeah.
And even on and I agree with the part about sometimes needing higher doses to get people calmer.
Yeah.
But I suppose it's not necessarily related to the melatonin release in that.
I don't think there's an interplay there, but one thing to keep in the mind is the stimulants exacerbate restless legs. And actually, that's probably something I should have put up too, right? So that would be something to think about there. Is it more of a restless legs problem? And then I guess the other thing to consider in those patients would be the genetic testing, right? The metabolism, because I suppose if you were a slow metabolizer, could you potentially be running in sort of high dopaminergic, adrenergic states at bedtime, right? But if we're really getting it first thing in the morning, and I would also question, I mean, I see these patients come in with ADHD and their sleep is all over the place. Some days they're taking their stimulant at 3 in the afternoon. Some days it's at 9. Like, how consistent is it actually, and what time are they taking it at, right?
I think that's where in kids it's sometimes easier, because I usually try to tell parents, like, if you don't give it by 9, don't
Yeah.
give it.
Yes.
Something like that, and that's where you have somebody else controlling it, and that person is desperate for sleep themselves. So they don't have motivation.
Yes.
As opposed to somebody living independently.
I would potentially wonder about metabolism, right? Especially, I think, in your patient population, there's differences. So, you know, can you go see the farm guys like Dr. Kim and get the genetic testing done, right?
So I'm going to introduce our next speaker. Dr. Marina Ybarra is a pediatric endocrinologist and deputy chief of the Pediatric Endocrinology Division at LHSC. And she leads the Pediatric HEAL program, which is Healthy Eating and Activity and Lifestyle. It's a multidisciplinary pediatric weight management program within the Ontario Pediatric Bariatric Network. And her clinical and research interests focus on childhood obesity, cardiometabolic risk, and improving outcomes for children and adolescents with complex metabolic conditions. So she's going to be speaking to the assessment and management of obesity in children and adolescents, including antipsychotic-associated weight gain. Welcome.
Thank you. Thank you so much. Thank you, Dr. Nixon, for the invitation to be here and talk about my favorite subject. So it shouldn't be too hard. So these are my disclosures. I try to be in everything that it's associated with childhood obesity and try to learn more and more about it. And there's not so much around in terms of pharmaceutical options, and we'll discuss what we have. But yeah, that's why I have so many listed there. So the agenda today is to assess pediatric obesity using a comprehensive clinical and psychosocial framework, to try to develop evidence-based management plans, including lifestyle, pharmacologic, and referral options, and then recognize and manage obesity associated with antipsychotic medications, including appropriate metabolic monitoring. So let's start. So obesity is a chronic disease, and this is kind of a new concept right now, that it's not you're doing everything wrong, you can't get it, and it's your fault. No, it's a disease that we should treat it. There's different guidelines that express the wording different, but basically it's a complex, relapsing, chronic disease that it's stigmatized, where there is excess body fat, and that's being more and more discussed lately because the Lancet joined a lot of specialists, because a lot of the obesity was decided on BMI only, and we know that it's not only BMI. So now there is everybody is more towards saying that you need to have a high BMI, but you also need other measurements of adiposity to say that you have obesity. And even if you have all of that, you can have preclinical obesity or clinical obesity, and that might, so only BMI now can be no obesity if you don't have any signs of increased body fat. And for that part, you can measure using waist circumference, that's more for adults, waist to height for children, higher than 0.5. If you have a bioimpedance like the HEAL program we're lucky to have, you can have a percentage body fat. Back in the days, dietitians used to do skin fold, any other measurement that shows that the kids are with higher adiposity. Then if you are there, then you can call it obesity. Is it clinical or preclinical? And then we'll talk a little bit more about that. So this is the BMI For children, as you probably know, we need the growth charts. Up to age 2, there was a long time that we didn't have BMI curves. Now we have it, so we can use it. But you can also use waist to height ratio before. And then you classify based on the percentiles now. For the longest time, we were using BMI Z-scores, and that's good for classification. But nowadays, they understood that the Z-scores is based on the number that we have collected. And it's a mathematical error, and I'm not very good at math, but it means that we don't have enough numbers to classify the higher categories of BMI Z-scores. So then you're piling up, and your patient is BMI. For follow-ups, it's not a good measurement because he will lose a lot of weight or change the BMI a lot, and the Z-score still doesn't show you that. So it's good for classification. I still use it. All the papers are around Z-score, so it's very hard for you to publish anything and not mention your Z-scores. But now we should use, especially if you're following up a patient, is percentage above the 95th percentile. So the easy way is just you plot in your curve what is the 95th percentile and how much is above, and then do the percentage. It's actually an easy count if you have your growth chart in front of you. And then if it is higher than 120, then it's class 2. I call it severe obesity, and then class 3, extremely severe obesity. That's the way I say it. And the other one is with obesity. So between the 85th percentile and 95th, it's with overweight. 95th and the 120 above the 95th, it's with obesity. 120 to 140, severe obesity. Above 120, extremely severe obesity. That's how I would name it. And people like class 1, class 2, class 3 also. So that's the prevalence in Canada. So I would say we're doing a good job. So it's not increasing in Canada, it's going down. Overweight's kind of the same, but obesity itself went from 14 to 10, from 2009 to 2019. I must say that if there are studies looking at socioeconomic status and that's only true for the higher socioeconomic status. For the middle and especially the lower, the prevalence is still not good. That's because it's also multifactorial. So there's so many roles that are playing at the same time when you're looking at obesity. So of course, there is individual factors, and I'll start there. There's genetic factors. There's genetic obesity, but there's polygenic obesity, and genetic plays a big role in both. In genetic obesity is the main reason. In polygenic obesity, it can account from 40 to 70% of you living with obesity. So still, you don't have a lot of room to play with, noticing that it's a chronic disease. Prenatal risk, so if you're born small for gestational age, you have a higher risk. If you're born from a GDM mom, you have a higher risk. If you're born large for gestational age, you have a higher risk. Postnatal risk, so were you breastfed? Were you not breastfed? Were you bottle fed? What's your activity level? Childhood risk is, do you have disabilities that impair you and you're not active and you can't enroll in any physical activity? Endocrine disorders. There's the family home, there's the parents, the feeding, the habits inside your home. And then there is the world that it's not helping, I would say, throughout the years. It's only more benefiting people who don't struggle with obesity or weight, I would say. So you can also say types of obesity. So primary obesity, most prevalent form, unknown causes. You have to exclude all the other diagnoses. So that's what most of the prevalence is. Secondary obesity, and that's why endocrine started, I think, take most of the referrals, and we have been studying more because most of the related disorders that comes with obesity are caused by the endocrine. So Cushing syndrome, thyroid issues, hypothalamic obesity. Some medications associated, and for the developmental disability kids, the antipsychotics. And genetic obesity, I'm gonna talk a little bit more today about genetic obesity just because most of the genetic obesity kids have developmental disabilities. So I think it's a place where we are gonna share a lot of patients if we are not sharing already. The genetic obesity, the most important thing is that if it is genetic obesity, it comes with hyperphagia. And then what is hyperphagia? It's very hard to define. There's some questionnaires that we can use in clinic that will help us, but I'm gonna share with you something that I just recently learned, and I think it's very good to memorize what it is and to understand it. So if we were all locked here, and these doors are closed, and we can't get out, and there was the same food from the lunch downstairs here, spread out, plus a snack bar here, like unhealthy things, plus some dog food here, right? We would naturally eat the food, share, rationalize as much as we can. Then we will go to the unhealthy things because they last longer and we'll go there. But we won't look at the dog food until we're starving. People with hyperphagia look at the dog food the same way they look at all this. And they will eat the dog food the same way because they're feeling that hungry as if we were locked here for 3, 4, 5, I don't know how many days it will take for us to go for the dog food, but they are like that every day of their lives, all the time, 24/7. So for kids would be a kid that eats right after, asks for more food right after, comes home, only asks for food, don't feel satiated, have tantrums if you don't give them food. And different aspects that you can ask. But that's the feeling that they have all the time. And that also comes, in my experience now, with more disabilities. Because if your brain is focusing on feeling hungry, like we're all grumpy when you're hungry, can you imagine feeling like that the entire day, 24 hours a day? You can't really focus on anything else. You're just thinking about what, when, where is the food, right? So it's very hard, I think. And it's different than binge because you can stand hours without eating. It's different than hedonic overeating or occasional overeating. You have to differentiate, but I think what I just shared with you is my recent idea of what's better. This is some characteristics and behaviors that you can see in kids with hyperphagia. So overwhelming, heightened, and relentless hunger resulting from genetic underpinnings. You have a severe preoccupation with food you're asking about all the time. Food becomes the major organizing of the home. So parents would say that if the kid comes from school and you don't have the snack prepped, like it's a major issue. You have a longer time to reach society, so you need to eat much more. There's a shorter duration of society. There's distress around it, and all these cues can help us define. And then for kids, when you suspect genetic obesity, then there is genetic obesity panels that we can do. Now, I don't know if you guys know about the uncoveringrareobesity.ca. It's a website that is funded by Rhythm. Rhythm is the company who developed setmelanotide, who is the only medication approved for some of the genetic obesity, and they are funding this for free. So if you have a suspected patient with early onset obesity and hyperphagia that you think might be genetic, it's different than your average patient, and you want to do the genetic test, you can just register your site here, and either you do it in your clinic, a buccal swab, or you send it to the patient's home, and they do it, and mail, it's all prepaid, and you get the answer in less than 6 weeks. And then, okay, I don't know, but I don't have genetics, they have it, so they can call, you can talk to the geneticist, and I've done that several times. The family can talk to the geneticist, so there is support involved. If you happen to find a diagnosis and you want to give to your patient before waiting for the genetic consultation or before they see me, if you're referring to me. From my experience at the Hill a year ago, that's not recent stats, but it's very rare that we'll find pathogenic. And that can be very frustrating. But and the way I put it to the families is like, your kid has early onset obesity and there's signs of hyperphagia. there might be a possibility that it's genetic obesity. There is now a test that we can offer you to make sure we know that. There's 3 possibilities of results. You can either have a positive result, and we know that he has genetic obesity, we know the name of it, we might or might not have treatment for it. There is negative, we didn't find anything in those 85 genes that we looked for, or there is uncertain. That means that we found something that is different than the general population, but unfortunately we don't have enough information and we don't know what it means. So that's how I frame it. I think each one of us has their own way. I'm just sharing how I do it. And most of the times they say, yes, I want to do it. And it's very, very simple. So genetic obesity accounts, so if obesity affects 10% of the Canadian population, 5 to 7, genetic obesity is only 5% of that 10%. So it's very rare. And within the rare, the most common one is the MC4R mutation, which doesn't have treatment. So it can be even more frustrating. But for some of them, now we have setmelanotide, which is recently approved by OHIP, and we can offer to families for patients with Bardet-Biedl syndrome. And we are trying to offer for patients with hypothalamic obesity. Yeah. So that's, we share a patient with that, so that's why I'm celebrating. It should be soon. In Europe, it's already approved, so they have been using already. And for other genetic obesity, for leptin receptor, for PCSK1, and for POMC. But I'm not going to go over because that's very specific. That's just some ideas that they are and they are not in the general polygenic and the genetic obesity. So for us, I think the age of onset is the most important one. It has to be below age of 5. I usually use below age of 6. Some people say you should use below age of 4. But yeah, 5 is the recommendation. Start of obesity below age of 5. It has to have hyperphagia as well. So it's early onset obesity and hyperphagia. That's when we get it. And the rest will come. So do they have developmental disabilities? Do they have other conditions? It comes as they grow up, so it's hard to, so I usually don't wait. If they have early onset and some signs of hyperphagia, I offer to the families. If they have early onset and developmental disabilities, I offer to the families to see if they are interested in looking at. Prader-Willi syndrome is the most common genetic obesity that it's not monogenic. It is associated also with hyperphagia, and it comes early in life. So the early features of Prader-Willi are very specific. Sometimes I don't find the right words, and I apologize. English is not my first language, so I'm looking for the word, but I can't find it, so I keep repeating myself, so I apologize for that. But yeah, so hypotonia and feeding difficulties. Like I just said, I'm originally from Brazil. In Brazil, we used to make the diagnosis of Prader-Willi in the obesity clinic. I haven't done any diagnosis here in Canada. I'm super proud that probably all of the patients were diagnosed in EQ. So I'm kind of not looking so much anymore for older kids with Prader-Willi, although still severe kids with severe obesity and some characteristics, facial characteristics and developmental I still kind of test because I can't really get rid of the fact that they're so severe and I can't find a reason for it. But I haven't made any diagnosis of Prader-Willi. And I think one key thing that it's easy for us to think about it or not is breastfeeding. So kids with Prader-Willi, because of the hypotonia, they can't breastfeed, they cannot latch. So if they were able to breastfeed, it's very, very unlikely that there is Prader-Willi. Even if they could breastfeed for 2 weeks, 3 weeks, they would never be able to latch with Prader-Willi. So I think that's a very good idea to have in mind. And later they have hyperphagia, very severe hyperphagia and rapid weight gain. There's also short stature, hypogonadism associated with developmental delay. They have so many other behavior and psychiatric features. And I'm sure you guys probably have seen some of those patients already. What is the behavior and psychiatric features of kids with Prader-Willi? So they have the hyperphagia, they have rigidity, they need the routine, They have temper outbursts, emotional dysregulation. They can't sit still. There's something that bothers him, then they can't concentrate, then they keep repeating themselves. They have the skin picking and the repetitive behaviors very much. They have anxiety, and they have increased risk of psychosis. We have just started doing more of a genetic obesity clinic at the HEAL program, and we just got all the Prader-Willi kids transferred from and different providers from Endo to the HEAL program. And I think we're gonna aim to do more specific follow-up for these patients. So yeah, so that's my goal at least. So that's the part to assess the obesity. How do we manage obesity? So in Canada, we have a very nice way of assessing it, and I love this framework. I don't know if how familiar you are. So it's the 5A. So you ask permission first to talk about weight. I know a lot of providers avoid to talk about weight. So sometimes we delay that conversation because it's not okay, oh yeah, you live with obesity, and just check and stop. So if you're approaching, you're gonna talk about it, and that will take time, and it's hard because you have a bunch of patients to see, so I can understand that. But once you start talking, the first thing you should ask about, is it okay for us to talk about weight today? Sometimes it's a surprise for them, the growth curve and the BMI, and when you assess it. So ask about it, and then assess, and the genetic testing will come there. Advise, agree on a plan, and assist with that plan. So that's the framework that we aim for. When you're assessing, you're looking for the 4 M's in pediatric obesity. So you look for the mental, and that's also when I mentioned the preclinical obesity and the clinical obesity, those are the characteristics you're looking to classify them into the clinical obesity. So do they have any mental health issues? Do they have anxiety, depression, body image, ADHD, learning disorders, sleep deprivation, eating disorders, trauma, anything mental health related? Mechanical, do they have sleep apnea? Do they have muscular pain? They are in pain all the time. Do they have reflux? Do they have incontinence, encopresis? I have all of those listed in my clinic. Metabolic, that's most of the GI and the endo, so type 2 diabetes, IGT, impaired fasting glucose, hypertension, fatty liver, gallstones, PCOS, and then medications associated. And then there's the last M, who is milieu, which is I translated as quality of life. It's what's the life of this kid? And then what's the family stressors? What's the family income? Is there bullying associated? What's the school attendance? Is this kid going to school? Is this kid able to tie their shoes? Can they wipe their bump? Like, how is their sometimes the blood work can look beautifully, but their quality of life, it's not. So that also is accounted here. And then there is this Stasia Hachinakis from CHIO, and the Canadian guys developed there's this adult framework, Edmonton obesity staging, and we did the pediatric one, and then you can classify it. And the 0 would be nowadays the preclinical obesity, and then it goes by the clinical obesity based on how serious it is. Usually I say stage 1 is you have something that is not, you don't need medication for, you don't actually need treatment. So let's say a low HDL and elevated triglycerides and ALT of 30, let's say, you're stage 1. Stage 2 is you have diagnosed sleep apnea and you're wearing the CPAP and you're good, you're sleeping well, you're doing fine. So you have a significant comorbidity associated with the weight, but you're treated and you're doing good. And then stage 3 is that you have 1 or more and you're treating, you're doing everything you can, and it's not under control. And unfortunately, that's the population that I'm seeing more and more now. Okay, so then treatment. So then the Canadian guidelines came last year, finally. We were anxiously waiting for our guidelines and the recommendations for treatment. So all these medications were listed here. Orlistat is out of the picture now. It's not recommended. It's contraindicated. Nobody uses it. So we're left with metformin and GLP-1s. Approved metformin is off-label for everybody. It's an amazing, and I'll talk about it. I'll talk about all of them. So let's go one by one. So metformin, everybody knows it. It's a very amazing drug for type 2 diabetes. It's the first line. We start with that, but it's never tested in kids, so it's always off-label in kids. But we have so many years of experience that we know, and it's a very safe drug. Improves insulin sensitivity, enhances peripheral glucose uptake, decreases intestinal glucose absorption. So your A1C, your insulin resistance is going to get better with that medication. Possible effects on gut microbiota and GLP-1 may influence appetite. The studies show that there is a modest weight reduction, typically 1 to 4 kilos over 6 to 12 months. If we're looking at that severe obesity or extremely severe obesity, 1 to 4 kilos, it's nothing. At the same time, if you stop gaining weight, it's already a success for us, right? So you're in a trajectory like this. If you change the trajectory or even flatten the trajectory, I'm celebrating, right? So it's a good try. The studies show like 5 to 10% of weight reduction. So it's not a miracle, and it's not something that patients get very excited about. There's side effects, and you probably know more than me, the GI side effects that they have. Some of them might not have any experiences. I was a big fan of metformin back in Brazil. We used a lot because we were doing insulin-resistant HOMA-IR, and we used the relationship between fasting insulin and fasting glucose, and that relationship was higher than 4, then you have insulin resistance. Then I came to Canada, and all the studies from my mentor in Montreal was like, okay, so if you have population with obesity, and then they transition through teenager years where there is a physiological hyperinsulinism. If you're with obesity, you have the hyperinsulinism from obesity. So they are normal glucose tolerance tests. They go through teenager years. They have impaired glucose tolerance tests. They pass teenager years. They go back to normal. So what are you giving medication for? To treat the labs? Like if you're not losing a lot of weight, you're not preventing diabetes. I'm working on a meta-analysis on that. There's no data. There's zero data that shows that giving metformin prevents or delays type 2 diabetes in children and adolescents. There is data in adults, but not in kids. And then a lot of those kids will come back to normal if you don't do anything. So why you're using it? So then I stopped using completely. Okay, no metformin. Stop metformin in my life. Then I met the guys from the Netherlands, and they have a lot of genetic obesity, and they use metformin for hyperphagia. So metformin increases, makes insulin better. Insulin better makes IGF-1 better. IGF-1 better makes leptin better. Leptin is the hormone that tells your brain that you're full and regulates your body. So maybe it helps with hyperphagia. They have no data. I came back, started using in my patients. That's the way I'm using. I say, let's try this drug. It's a safe drug, it's off-label. Let's do a trial. It might work for you, it might not work for you. Let's do it for 3 months. I'll see you in 3 months from now. If it works, we keep it. If it doesn't work, we ditch it. I'm gonna say it's been a 50-50. It works for 50% of my patients, and it's a good drug. It's not an injection. You can use it 8 years of age and up, and it's a pill. There's a lot of benefits around it. And I don't know if you put a lot of the placebo in it, saying like it might work for you, it's a solution. Who knows? Like we don't know the power of placebo, right? Sometimes if you're trying something with so much putting your heart into it, I believe that might work a little bit better. So that's how I've been doing nowadays. Okay, the risks are GI upset, rare but serious lactic acidosis, so disclosure that with your patients. Should we monitor B12 levels? Use with caution if kids have renal impairment. Start with the low dose and titrate slowly. I do that. I do 500 a week, 1,000 another week, 1,500 another week, 2,000, and keep 2,000. So every week I go up, and 2 grams is the higher dose. I think go all or go nothing. Like 500, and that's the Netherlands groups go up to 1.5 grams per day. I think, and everybody says 500 doesn't do anything. So if you're doing just low dose, it's better to, it's not doing anything, for weight at least, right? Not for diabetes speaking. And then there is the GLP-1s. So we started with Saxenda. GLP-1s is a gut hormone that is produced in the end of our intestines. Once the food gets there, it kind of tells the brain, hey brain, there's food on board, you can stop eating. And it tells the pancreas, hey pancreas, there's food here, there's sugars, you can release the insulin. So then that's why it started being used for diabetes. Then people said it was shown that you lose the weight, and then they started branded for obesity, right? So it's the most common now is Victoza. So Saxenda is the same as Victoza, same drug, just different branding. And Wegovy is the same as Ozempic, same drug, different branding. This one is daily, the other one is weekly. Why you're taking daily if you can take it weekly? Then weekly is better, and the results are different. Wegovy shows better results, and it's not based on, because in the beginning we were saying, oh, it's better because you're taking it, you're not forgetting it, right? No, like it's a fact. Like Wegovy is much better than Saxenda, the results. And here it is the Saxenda results, the change in weight compared to placebo. Then you stop after the trial is done, and there is the regain. So that's a question that everybody makes, including me. This is Wegovy, and it's a better, you lose like about 15 to 20%, they say. So Saxenda, it's 5 to 10, and then Wegovy, it's 15 to 20%. So it's better results, it's a better drug. Indications of both, you have to be 12 years and up. Saxenda was published, the data between 6 and 12 in the US. FDA is approved, not in Canada. It's kind of being discontinued. I don't think we're gonna have the approval here. I don't even think they're applying for it. So for under 12, no GLP-1s are approved. So 12 and up, not covered. If some insurances cover it, and then you have to fill out a form. So I usually say, call your insurance, see if it approves. If it does, usually there's a form, send me the form, I'll fill out the form and we'll do it. It's not hard to fill out. It's just like BMI stuff. It's very easy to go through. Contraindications. So the only formal contraindication is if you have a family history of men to thyroid cancer. This was only seen in mice, rats. They were never seen in humans, but it's formal. So I feel like it's also a conversation with the family about it. But other things that you should disclosure is there is a higher risk of pancreatitis, gallbladder disease, bowel paralysis. They are not contraindications, but it might happen. I usually say most common side effects are nausea, vomiting, diarrhea, constipation, like GI. If you have that and you're struggling, let me know. I'll run the blood work for pancreatitis, gallbladder disease. All of my patients, none had severe side effects in terms of the blood work. And then I say, I usually use ondansetron for the nausea. It helps a lot. They must have insurance. If they don't have insurance, we'll come back asking for the chemotherapy that they're using, so you can't usually prescribe it. And it's pricey, so they won't pay for it. So then you have to live with gravel, which is not the best. I usually tell them to take it at Friday nights. So take it at Friday nights, because if you have side effects, you're not missing school. This is supposed to be your friend, your allied in your journey. It's not supposed to make your life miserable. It's making your life miserable. Talk to me, let's ditch it. Or you can always titrate back the dose. So both of the drugs, it's a titrating up. So you start with a dose and go up every 4 weeks until you get to the max dose. You can always titrate back. In one of my patients who I have no other option, I'm counting the clicks, titrating back the 0.25 pen to see if he can tolerate. So there's always options. I'm happy to discuss with you guys if you have any patients that you want to discuss. To do so. So this is the most reported side effects, and it's my experience as well, nausea, vomiting, diarrhea. I would say 75% of my patients, no side effects. Love the drug, check, keep going. 20% of them have side effects, 15% are manageable, and we treat it, and by the 3 to 4 month mark, that's what the trial said as well, fade side effects, so it goes away and you can live with it. 5% won't tolerate since the beginning, like severe diarrhea, puking all the time, can't tolerate it. 5% you try to treat, but they kind of get discouraged and they say, oh, no, this is not for me. So that's my experience. The European group, they say, and there is reports saying that there is fail of the medication. So you give it, they tolerate it, and it's not working so well. I think it depends. Like I have one patient that it's not gaining, is still gaining a little bit on the Wegovy, but he lost a lot in the beginning. A lot of them have less effective, I would say. I wouldn't say not responsive. Because like I said, if you stop gaining, for me it's success, right? And if you need Wegovy not to stop gaining weight, like gaining, I can't imagine how would it be if they were still gaining. So I think that's discussable. Success in weight management, it's been a challenging, we talk, like a lot of the papers, it's decreasing 0.25 Z-scores in your BMI. Is that more important than your quality of life or going back to school or talking to your friends? Maybe that's your objective. So just, I think there's several ways of looking at it. Mental health outcomes. So there was a lot of bubbling in the literature about depression and Wegovy, suicidal ideation and Wegovy. What do we do? Is there evidence? I looked it up. So most of the evidence says that it gets better. So depression gets better, suicidal ideation gets better. It's popping up more and more literature showing that it improves mental health. But there are some case reports of suicidal ideation. I have one patient that had a suicidal, I'm not sure if it's Wegovy or it was his mental health because he was already with severe mental health, but it's something to keep in mind. If your patient is already with severe mental health and suicidal ideation, that it might have a risk of increasing that. For setmelanotide, so setmelanotide is the drug that I mentioned for genetic obesity. It's also an injection. It's very expensive and it helps with the hyperphagia. So this is the weight of the trial that they did. When you report the total, it's not so significant, but I tell them that I like this slide more because, okay, there's a patient that went from 261 to 101. He's still with obesity at 101, but wow, right? So you're celebrating. This one was with obesity, and now it's a kind of healthy weight. So I think there's variances, but what it's shown, oh, and I excluded the slide, sorry about that, it's the hyperphagia. So what they did is they did a double blind and then they open label, and hyperphagia goes really down. So the quality of life of patients on setmelanotide that have genetic obesity, it's increasingly, like, it's amazing because they stop with that mental thinking about all the time. And then they when they opened and everybody transitioned to the drug, it paired up. Everybody, hyperphagia is down. So that's the beauty about it. And then but the thing is, the insurances and everybody want to see the weight, right? So, which hyperphagia, it's hard to measure. How do you prove that they are better? So there's all these nuances in clinical and research, I think. Okay, so the antipsychotic piece. So when you start a medication, some antipsychotics have a disruption in the satiety MC4R pathway signaling in your brain, and then it can increase your hunger and decrease your satiety. And I'm very biased because I only see the ones that are having that. And you guys see all of them, so I'm hoping that not all of them, Dr. Nicholson, of your patients have their own antipsychotics are having this side effect. But I'm super biased because I only see the ones that have the hyperphagia and are gaining weight, and you guys are referring to me. And so it's impressive. Like, they start the drug, they start gaining weight, and it feels like the genetic obesity just goes straight up. The trajectory changes completely. The ones who gain a lot. And weight gain is not just behavior. They're feeling hungry all the time. So it's not their fault, right? So it's something that we should acknowledge. Like I tell them, this is not your fault. Let's work around it. Let's try to do the best we can. And some patients would say, like, parents would come to me and say, please don't change the medications. He's so much better. He used to beat us up and now he's doing so well. So you have to manage as well. So this is the literature review that I did. Highest risk is olanzapine and clozapine. Moderate risk, risperidone, quetiapine. Lower but not weight neutral, aripiprazole, lurazidone. I don't even know how to pronounce those names, guys. Okay, so in my experience, in my clinic, what I see a lot is patients on risperidone and aripiprazole. And in my experience, completely biased, it's not lower. Like, I hate this drug. I don't know, for some reason. I think maybe my hypothesis is that most family docs and pediatricians are more comfortable with these two drugs, so that's why it's more prevalent in the population. So that's why I receive the most of the referrals, whereas the other ones are more like psychiatrics that use it. So maybe pediatricians and family docs are not so comfortable with using that. So there's a lower population that have access to a psychiatrist, that have access to those type of drugs. That's just my guess when I was prepping for today. Children gain more weight than adults on antipsychotics, and rapid gain often occurs within the first 3 to 6 months. So early monitoring, see your patients closely, and I'm sure you're seeing them because you need to adjust the dose to see if it's working. Check the weight, put on the growth chart. Sometimes he's skinny and he just gained a little bit, but the trajectory changed. Like, did the trajectory change early with the start? Consider, I think, then what do we do, right? So then, okay, I have this patient, I started on the drug, he's doing better for the behavior, but he's gaining a lot of weight. What do I do? So prevention, talk to the family, do all the assessments, try as much, like the sleep, try behavior and everything, lifestyle, which is very tricky and time and life consuming, but do that. And then medications, can you switch? So I think one strategy is, can you switch? Is there anything else that you can try that is a lower risk? I think that would be my first approach. No, can't switch, that's the only one, that's the one. The evidence shows metformin. There's not enough, so I'm trying to do a trial on GLP-1s and antipsychotics. It's been challenging, maybe I'll do it. Maybe there's other people already doing it. For the patients who are being referred to me, I've been starting Wegovy right away. For 12 and up, on antipsychotics, they're already with obesity. When they come to me, start Wegovy, and it helps. Like, and there is some adult data that shows that it helps. The pediatric data shows metformin helps. And then when you look at the results, and there's other options less robust for medications. If you're comfortable, if they have headaches, if you're comfortable with topiramate also is an appetite suppressor. I'm not so comfortable with it, so I don't tend to use it. But if my headache colleague uses it, I love it. So that's where I am right now for topiramate. DBT, social worker, cognitive therapy, all this part as well. In Brazil, sibutramine is approved. I don't know in Canada if it's approved or not. This is, yeah. Yeah, so this was, for weight, was really, really good. And we used a lot. So I had experience, we did a trial and it does really help, but I don't know. So yeah, so the evidence is on metformin. So maybe you could also try the way that I do for hyperphagia, do the 3-month trial and see if that's something that works for them. The results in the literature for metformin, so the studies, sometimes you look at numbers, right? So you're looking, okay, there is a difference between the two groups, but the weight loss is minimal. So for my patients, I really feel like they're already like here with severe obesity, I'm giving metformin, and they're still here. So maybe it will help stop the trajectory, but it won't actually help them to lose weight. And that's what they're looking for most of the time, right? They want to get back to what they were before. So I think Wegovy is a good option to try. So yeah, so childhood obesity is a chronic biological driven disease, multifactorial. Assessment matters, so use the 4Ms, use the Edmonton, classify, is it obesity, is preclinical obesity, is no obesity, maybe it's just the BMI. Treatment lifestyle is necessary, but most of the time is insufficient. Different from the sleep, I think lifestyle is very tricky. With most of the patients, they are more with the clinical obesity. I would say preclinical obesity and very early stages of obesity, it's helpful. And I have discharged patients from the clinic when I was accepting very non-severe cases. GLP-1 is the most effective drug right nowadays. I love it. Pay attention to this. If they're gaining weight, I think that's the most key. And then if you can switch, try metformin. If you're comfortable, try Wegovy. Or send it to me, but my wait list is terrible right now. And yeah, think early, prevent. I don't think any of us do a lot of this. If you're doing, maybe you do in your family practice and then treat, monitor, act early, consider to switch. And yeah, and I have so many people I would like to thank throughout my journey, but mostly now this is the HEAL team. So we're doing education sessions. Anu is here, it's the social worker, Octavia is the dietitian, me and you is the clinical coordinator, Julie is the nurse, and Cindy is the physiotherapist, and it's missing Milan, who is the assistant, administrative assistant. Yeah, thank you guys.
We're going to take a break after, so if we have some questions for 5 minutes or so, we can fill those. I'll start first. What about your experience with Mounjaro? I noticed
it's not approved in kids. It's soon. It's called tirzepatide. I tried to hook up in the trial, but they closed they didn't pick me. They picked 2 centers in Hamilton that are doing. So there is a trial happening in teenagers. It's going to be amazing. It's going to be better than Wegovy, like it is in adults already. Yeah.
Diarrhea with Wegovy.
Okay.
Mounjaro's.
Yeah, it's way better for the side effect. It's better weight loss and it's better side effects. Yeah. So I think even in Canada it's only approved for type 2 diabetes now. So not for obesity yet, I think, insurance-wise.
Yeah, but and it's very expensive.
Yeah. So so in Canada it's always the last to get approved, and then it's always the last to get paid for, if it's ever going to be paid for. We don't know.
Question over here.
Just a really quick question as social worker. So cost is often a huge issue for a lot of the families we service. So I was just trying to understand from the insurance piece, are you talking private insurance? Okay, so the Canadian drug plan.
No, none of them. So for these patients, I have a creative way of prescribing. So the Wegovy pens, they are from 0.25 to 2.4 pens. They're not rotating. So each week that you're increasing, you have 4 doses. So if you're on the 0.25 week, you have a pen of 0.25 with 4 doses of 0.25, right? So that means that the 2.4 pen has 4 doses of 2.4 milligrams. So I prescribed that one, which is now just changed the price from $400 to $300. So this is $300. So then you count the clicks of the pen. That's around 75 clicks. And then you calculate 75 clicks is 2.4 milligrams. 0.5 is X amount of clicks. So roughly you start counting the clicks, and I go up to 1 milligram. So 1 milligram is the dose for Ozempic, which is the diabetes drug, and there is weight loss there. So then the pen will last them 10 weeks. To start with, the 0.25, I can send you the number of the wrap. Krista will give you samples. So you can start them on the samples, see if they tolerate it. Let's say, okay, I like it. I am committed to paying. Prescribe the 2.4 pens, and I can share with you guys the click method, I call it.
That would be great.
And I disclose right in the beginning, right? I say that's a creative way of outcoming the costs. The manufacturers say that it lasts in the fridge for 8 weeks. So in theory, after 60 days. After 60 days, you have to throw away the pen. I say it's up to you. I doubt that the drug is going to not work. It might work 80% of the 100%. It's still the money you pay for, and it's going to work somehow. So, and it will last 10 weeks. So then every 2 months and a half, it's $300. It's kind of feasible. I think for most of the patients, a lot of them who really want, they'll go on. So that's my experience so far. But then I don't go the max dose, right? I go to 1 milligram, but it's still good.
Fantastic. Okay, thank you.
Yes.
Practically, how are you giving the metformin to younger kids or kids with disabilities? Are you crushing it or compounding it or?
Yeah, crushing, putting in applesauce, yeah, I have one patient with Prader-Willi that the parents came and said her cognitive level impaired. It's so much better. She knows her name. She knows how to count. She's interested in things. And then I remember talking to Fambi with a colleague of Endo, and she say like, Marina, it's not metformin. And then I came home and I was like sleeping on it, and then maybe it is. Maybe she's not with hyperphagia anymore. Maybe her brain has space to think about other things, and now she's functioning better. That's what the parents can say. And she lost weight. She lost a lot of weight, and she's better. She's happier. The families. So maybe it's a miracle drug for some proportion of the patient. It's worth trying. It's covered, at least.
Okay, so if we'll take a break and maybe be back. It's my pleasure to introduce Joan Gardiner. And Joan has worked as a speech-language pathologist for 25 years. And she's graduated from Western with a Master of Clinical Science degree, and before that was at Brock University. She has supported clinics at CPRI that serve children and adolescents who have neurodevelopmental disabilities and or mental health concerns. Currently, she works as the outpatient interdisciplinary autism service and 2 inpatient services. She completes assessments and provides consultation to support clinicians and caregivers, understanding how about communication skills might influence a child or adolescent's overall profile of presentation, including their strengths, needs, and or the use sometimes of challenging behavior for communication purposes.
I'm super excited to be here. My little claim to fame is that I worked here at Spencer Hall when I was a teenager. And so I feel like I've come full circle now that we're here to do like actual grown-up professional work. So we're going to talk about language disorders today. When Rob asked me if I would do this, I said, I don't have the expertise to talk about developmental language disorders. But then he pointed out I've done it for a long time. And when I was making up my slides, I think I've got way more information in my slides than you could possibly want to know, or that we might even have time for. So we'll skip through and get through what we can and tell you what we can so that you leave here feeling like you've got some knowledge. Okay, Jason told me that if I put, wrong button, there we go. Okay, so I have nothing that I have to declare that is interesting. And our agenda for today is that we have 3 things that we're hoping to achieve today. Maybe you'll take more away from the presentation than just 3. Maybe you won't take 3. But I do want to talk about the terms that we use in our profession. So I want to talk about the terms of speech, language, and communication so that when people are talking about those things, they're talking about the right things. I want to talk about maybe what are developmental language disorders, how do we recognize them, and why does it matter? And then we'll talk a little bit more about what are the components of language where disorders might happen so that we can understand how they might influence the profiles of the kids that we see, the challenges that they have, and the supports that then we would introduce accordingly. Okay, so we'll start with our goal number 1. We'll knock that off right now. So in terms of the field of speech-language pathology, we talk lots about communication, we talk about language, and we talk about speech. And I think the reason for clarifying those terms before we go any further is that I think sort of these are words that we use, these are words that people use all the time. And so I think it's very easy for them to be used sort of colloquially, and they get interchanged with one another. And we might not actually always be talking about the same thing. So it's not uncommon really for me to get a referral for a speech assessment when really what the person who's referred is looking for is a language assessment. Or if a child is nonverbal, again, they're not looking for a speech assessment, they're looking for a communication assessment. So we'll start by just talking about those terms so that for the next 40 minutes, we know that we're all talking about the same thing. So communication is really the transmission of a message. So it can happen in a lot of different ways. It's any verbal or nonverbal strategy or behavior that allows us to share a message from one person to another person. And really what we use communication for, obviously, is to influence other people and to let them know what we need or what we want. And it involves then the sender and a message and then a receiver.
And we can communicate in lots of different ways. We are going to talk about language, and that's one of the ways that we communicate. We can also communicate through body movements. We can communicate through the tone of our voice. We could use interpretive dance if we wanted to. If you think about bees, they send messages to one another through the ways that they move their bodies. Okay, so that's communication. It's a big, broad umbrella term. Language is a conventional symbol system. So the sounds and the words that we use in a language can be put together in a really rule-governed way, and we can use that to share really specific and meaningful information with one another. But a language, it's a rule-governed system. We have lots of different languages. So English is a language, Latin is a language, ASL is a language. They all have their own symbols, they all have their own rules, but they're very systematic and they're governed in terms of how you would use them. They are, though, arbitrary, right? If you think about it, in English we call a cookie, in French we call it a biscuit. So we're talking about the same thing. Arbitrarily, we've picked that string of sounds to represent that item, but we do that in a consistent way. So I always use the word cookie when I'm talking in English. However, language is dynamic, and so we add new words, and sometimes old words fall off as well, right? If you think about, 30 years ago, we didn't use the word Google as a verb, but these days we do. And so we use those symbols in a really systematic and rule-governed way. We use them predictably and we use them consistently, but we do add and we do subtract as we go through. And what we do is we select those symbols, we put them together in order, and that's how we convey meaning to other people. Speech, on the other hand, is that auditory signal. It's what you hear. It's the production of the sounds that we make so that we can use those symbols, those words, to share information with one another. So it's that oral signal. It's maybe what people would refer to as articulating those sounds and getting them out. So communication, language, and speech are not the same things, but they do exist within sort of the hierarchy of communication. So I said at the beginning, communication is an umbrella term. It's the way we send messages from one person to another person. We can do that in different ways. We might do that intentionally. I do that with language in an intentional way. I'm using words and symbols on purpose to share information. We could also do it unintentionally. If I was standing up here and I was shivering because it was really cold in here, I might not be sending you a message on purpose, but you still might be getting a message from me that I'm cold, right? So communication can happen on purpose and not on purpose. If we're doing it in an on-purpose way, we're typically using language. We're using that symbol system. If we're doing it non-verbally, there's lots of different ways we can share information with people that way. So we can use gestures, we can use facial expressions, we can use even things like how close or how far away I stand from my communication partner tells you something. The intonation, volume of my voice tells you something. Or we could use lots of times with our developmental disability kids, we use images and sort of those non-verbal ways that we would communicate as well. Language can also happen in lots of different ways. So we have spoken language, that's what I'm using right now, but we could also have written language, we could also have sign language. Those are all systems that use symbols in rule-governed and conventional ways. So we're going to talk about developmental language disorders, so we're going to talk about what is language. That's going to be sort of the focus for today. So language is really a very human construct. So it's the way that humans share information with one another. And we're really the only species that has developed this conventional symbol system by which we share information with other people. And like I said on that previous slide, it's conventional but arbitrary, right? Cookie is cookie for us, it's biscuit for the people who speak French. But we do use it in a rule-governed way. And so you can see my little image here on the side, so we know that there's a sentence. And in English, we have a noun phrase and a verb phrase, and we can break that noun phrase down into a determiner and a proper noun. We can break that verb phrase down into a verb and a prepositional phrase. We can break that prepositional phrase down, but it's all done in a really systematic way. And I think for those of us who use language, especially our first language, those are skills that we learn really innately, and we don't really think about it. But when you stop and think about sort of how you know something sounds right in your language, it's because you're really implementing those rules. And I think for people who are learning a second language, that's where you realize how much of a rule system it is, because you have to learn those rules of a different language, and one of the things that makes it challenging. So language, like I said before, can happen in lots of different modalities. There's different symbols that we can use. We can use that oral signal speech and those symbols of spoken words. We can use the letters for symbols in a written format. We can use hand gestures in a conventional system of sign language. What makes language fascinating is that we can use it at two different levels. So what I call core level language is sort of that concrete meaning, those symbols that have meaning and they're very definitive. And that's what we call literal language. So when I say something, it means that. but we can also use language in an abstract or a sort of more conceptual way. So non-literal language. So I could say a sentence, it's raining cats and dogs out there today. Well, it's not actually raining cats and dogs. So those symbols start to be used in different ways, and there's different ways in which we can use that to share information with one another. So this was just a dictionary definition of what is language, right? It's that by using these symbols that people, humans, are able to impart information for lots of different reasons. And it's something that makes us pretty unique, I think, in this world. And it's something that allows us to go far, far beyond sort of the here and now. We can use them for really arbitrary ways. We can do really amazing things because we have language. Okay, so languages, this slide is maybe a little bit redundant, but really it is the primary way that we interact with our world, right? So that slide that I showed you before with all of the different ways that we can communicate, but language is the one that we use most often, and we use it for all of the tasks of everyday life. And there's many, many functions that we can accomplish when we have language. So language is a primary modality of learning, right? We've sat here today, we've listened to people talk. That's how we've gathered information, and we've learned new things about sleep and about obesity. It is also critical to social interaction. When people went out for a break, I bet you stood around and you talked to one another. You used your language. It is how we regulate our own emotions and our behaviors, right? We can talk ourselves down, we can think our way through challenges, we can think about options that exist when we're problem solving, and we do all that through thinking in language. And it's also how we plan for our future. We think about what has happened in the past. And I think what's fascinating about language is that for most people, the development of language, this really complex, really sophisticated system, it just happens naturally. And because it happens so naturally, a lot of people don't even recognize that it's a skill, right? It's just something that we do it with ease. But it doesn't happen that easily for everyone. Before we talk about how it doesn't happen that easily for everyone, some of the things that we don't even think about when that language happens naturally is there's lots of different pieces of language, that system of language. If you think about any system, a system has parts. Well, language has parts. So the parts of language are what I refer to throughout the rest of my talk as, and these aren't my words, these are sort of the words of the field, form, content, and use. So form is the structure of language, and we'll talk about that. So the structure of language, right? We have the individual sounds that we put together, and those sounds in combination make different words. We have little component parts that we can use over and over again in language that convey meaning, morphology. So if I put the an S sound at the end of a word, it means that it's plural. There's more than one of them. And if I don't have that S sound there, it means that there's not more than one of them. Or if I put an ED sound at the end of a word, it means it happened in the past. But if I put an ing sound at the end of that verb, then it means that it's happening right now. Those little units give us meaning, and we use those units over and over, right? I can be walking, I can be running, I can be jumping, I can be skipping. Those are all different actions, but they're all happening right now because I've put the ing on the end of them. And then syntax is those rules of grammar, like I showed you before with that little grammar tree, how we can put those words together in that system of language to share information. Content is the meaning of language. What do individual symbols mean? What does the word tree mean versus the word cookie versus the word jumping, right? Those all mean different things. And the way we store meaning and the way we access meaning is part of our language system. And then there's an element of how we use language. So that's what we call pragmatics. And there's lots of different ways that we use language differently. The way I would use language to speak to my friend or my husband at home would be different than the way that I would use to speak to my boss at work. And so the logistics of using language is influenced very much by our social context and even the words that we choose or the tone of voice that we would use. So when we're talking about language, we're going to talk about form, content, and use. We also use language for two different reasons. We use it receptively to receive messages from other people, and we use it expressively to give messages to other people. And when we're going to talk in a minute about developmental language disorders, we're going to talk about sort of where breakdowns can occur in all of these different components of language. So, as some would say, a rose by any other word would smell as sweet, right? And I think when we're talking about language disorders, what speech-language pathology maybe has not done well historically is picked the word that we're going to use. And I think part of that is because we see language disorders in lots of different fields, right? We see them, I'm sure people see them in medicine, we see them in education, we see them in speech-language pathology, and we all use different words to refer to this group of kids. So this is the list of words that have sort of traditionally been used. And what we're going to talk about now is sort of why we're going to use the word developmental language disorder for the rest of the presentation. And maybe I could even convince you that that's the way to go moving forward as well. So we're going to talk about developmental language disorder. In the DSM, it's called language disorder. So they've left out that developmental part. But it has a lovely little acronym. You can call it DLD if you put that extra developmental in there. And so, we like acronyms. Okay, so part of the problem is that many years ago, as I said, we had lots of different terms for referring to what are problems with language and language development. And so in 2016 and 2017, there was a consortium that came together. I think it was 59 people, experts in the field. They came from different disciplines. They came from medicine. They came from education. They came from the communication disorders field. And they said, you know what, we've got to settle down and sort of figure out some guidelines. So the Catalyse group, what they did was they used a strategy called the Delphi method, which is sort of a consensus approach to identifying what are the criteria for what we consider to be a developmental language disorder or a problem with language at that point in time, because the next year, 2017, was where they decided what we were going to call it. So that's where the term developmental language disorder. So if anybody wants to know lots about developmental language disorders beyond what we talk about here, those are great studies to pull information from, because it really talks about all of those folks who came together with their wealth of knowledge and what they did and decided did and didn't fit in terms of what are language disorders, developmental language disorders. And so this is what they came up with. So a developmental language disorder then is a communication disorder that affects an otherwise typically developing person's ability to comprehend, receptive, and to use expressive language. And so it exists in the absence of any other reason why somebody might have a communication problem. So it's something like a hearing impairment, an intellectual disability, some sort of genetic syndrome, brain damage. So we're not talking about those kids. There's lots of folks who can have problems with language who have lots of reasons for having problems with language. But for the rest of our talk today, we're going to talk about developmental language disorder, which is that we don't know the cause, and we don't sort of associate it with any other contributing factor. But we do think that it's probably influenced by genetics. We don't have great studies that talk about that, but there is a 20 to 40% incidence of language disorders recurring in families, and so that's a pretty strong indicator that there is a genetic influence. What's interesting, though, is that we say that it affects about 7% of school-aged children. And why I think that's interesting is that, again, I don't think developmental language disorder gets a lot of attention or a lot of credit. I don't think it's a buzzword that people are throwing around. We talk lots about autism. We talk lots about ADHD. But those are actually conditions that occur less commonly. And so developmental language disorder affects a lot of kids. I think part of the problem was we didn't have good terms. Remember that slide from before? We were all talking about it in different ways. And so I think it's kind of gotten lost. I think it's made it hard to do research because we're not sort of using the same language, if you will. But it's a pretty popular and persistent problem. And it affects kids from an early age. It affects them through their early education and later in learning. And it actually persists throughout the lifespan. And it just sometimes looks different at different ages. But it can affect language. Developmental language disorder can affect those areas that we talked about before, the form, the content, and the use. And it can affect them, some in more areas, some in less areas, differently for different people. And so that's also made it kind of difficult for us to put our finger on what can be a developmental language disorder. The other thing about it is that it's invisible. So kids who have developmental language disorder typically are still talkers. They're kids who talk, they use language, they use words, and it can be really hard to recognize when problems happen, because if kids talk, because for most of us language happens so innately and we take it for granted, we don't always even recognize that if they're talking there still might be a problem. And so I'm going to show you a little video of what developmental language disorder might look like in this cute little kiddo that I took from YouTube. It is nobody that I know.
Hey.
Hey.
How you doing today?
Good.
What's your name?
Aubrey.
What grade are you in?
Third.
How old are you?
8.
So, what book did you just read?
Author's Lost Truth.
Was it a good book?
Yes.
You want to tell me about that book?
Yes. Well, most of the things like that, authors first do. He wanted to come out, and then And then it's Sister Violet. It's scared of the dark. She's scared of the dark. And she came, and then she yanked the doorknob, right on the doorknob, and he pulled, and then the babysitter came, and it came out, and then it was a good book. And then marshmallows, s'mores.
So
That's it.
the reason why I think this is a great little video of Miss Aubrey is that she is a talker. She sounds good. Her articulation is clear. Her intelligibility is good. She's using words that we know. They're probably words that are relevant to the story that she's read. She's engaged as a communicator. And yet at the end of her synopsis, I don't know that any of us have any idea what happened in Arthur's loose tooth, right? So as a communicator, she's pretty ineffective. But she looks like she's a talker. And so I think at times it looks like Aubrey loses attention because there's sort of these long pauses. But I would suspect that Aubrey can't quite find the words that she needs, and she's not able to put those ideas together with those symbols of words and to share information in a meaningful way with another person. So what makes, again, developmental language disorder interesting is that if you think about language development in the earliest years, and we've got some pretty good milestones. We know what we're looking for when kids are little and when they start to talk. So from about sort of 9 months to about 4 years, we have all these milestones, and as parents, we all check them off, and we want to make sure that they're doing well. And really, in those early years, what kids are learning is the vocabulary and the grammar, the form and content of language. But language development doesn't only happen in the first 4 years. So language development also happens throughout childhood and throughout adolescence, and language continues to develop throughout adulthood. But what we don't have throughout childhood and adolescence and adulthood are those really clear developmental milestones that we know what we're looking for. And that's partly because the language development changes. So rather than being about form and content, it's a little bit more about content and use, how you use language. They're learning new words. They're learning words that are more relevant to the experiences that they're having. Their sentences are getting a little bit longer, a little bit more complex, but not in a way that we can tie down in a nice, neat little chart the way we do in those first 4 years. And then even into adulthood, if you think about when you start a new job, you learn words that are associated with your new profession, or if you pick up a new hobby, you're learning new things like that. So language development continues, but it's a little bit harder to identify what are those specific markers of development as people get older. So why is this a problem? Well, it's a bit of a problem because it's really easy to see when those milestones aren't being met when kids are little. However, what we know is that we actually can't identify well kids who have developmental language disorder when they're in that chart of 0 to 48 months. What we know is that some kids who are defined as late talkers, so they don't talk a lot, they don't know a lot of words, they don't start to put words into longer phrases, that those kids actually might catch up. The trick is we don't know yet which ones those are going to be. So about 40 to 50% of kids are going to catch up on their own, and we're not quite sure who those are going to be. The other thing is that some kids that are later identified with developmental language disorder actually are not late to talk. So they might be meeting those milestones tickety-boo, and we think everything's okay. We do know, like I said before, there's a slight trend that they are more likely to end up with a developmental language disorder if there's a family history of language problems. And we do know that at this age, though, other issues that might affect language might not have been identified, right? So there might be hearing issues, there might be learning challenges, there might be other factors that are at play. So what we know is that we can't necessarily just do a screening or an assessment when a child is sort of below the age of about somewhere between 5 to 7 and identify who's going to have a developmental language disorder. But we do know that the greater the number of difficulties that they have, the greater the likelihood that problems are going to persist. Those problems, though, might not be a developmental language disorder. They might be something that gets identified in those other reasons why a child has communication difficulties. But they are kids that we're going to watch. So I'm not saying we should get rid of the assessments for preschool kids. I'm just saying that what they tell us in terms of developmental language disorder might not be as significant as we might hope. What we do know, though, is that by about the age of 7, that's where we're starting to be able to really pick out these kids who meet the criteria for a developmental language disorder. So what's interesting, though, is that, again, we talked about those late talkers. So some kids who had those difficulties when they were young no longer have problems. Those kids have resolved. We don't know which ones they're going to be, and we don't know why they've resolved, but they have. We also know that some of the kids that we identify as developmental language disorder at the age of 7 didn't have those problems earlier. We talked about that when we were talking about the 3-year-olds. But if kids have problems at the age of 4, and if they still have problems at the age of 7, then we're going to be pretty concerned about them, and we're going to expect that their challenges are going to persist. And we know that kids who are having difficulties with spoken language at the age of 7 are also at risk for ongoing issues in terms of language and literacy and learning and all of the things that go with that. So we also know that kids who have receptive language problems are more likely to have ongoing difficulties than kids who have those expressive type difficulties alone. So there are things that we can tell and things that we should be concerned about, but there's also sort of, not a clear path that we can pick out when kids are really little. So if we want to look at, well, where can things go wrong for kids in terms of language development? We talked earlier about the components of language, the form and the content and the use. Well, if we've got those components of language and we've got a system that's not working well, then the things that can go wrong are things in the areas of form and content and use. So in the areas of form, so phonology, that's the sounds of the language. Morphology, those are those small meaningful bits that we talked about before. And then the syntax, that's the rules of grammar that we all learn to follow. If kids can't discriminate those sounds well and they can't hear the difference between a t and a k, then they don't understand the meaning difference between t and key. And that's going to have implications for them in terms of learning that symbol system of language. Those different sound systems, signals mean different things. If they aren't able to pick out those small grammatical pieces, like I talked about before, if they don't understand or hear that the S at the end of the word means that there's more than one, they're not going to understand singular versus plural. If they don't understand the sentences as they start to get longer, more complex, when we start to use words like conjunctions, we put multiple ideas together and our sentences get longer. If they can't crack that code of that little grammar tree that I showed you earlier, then they're not going to be able to pull the meaning from that symbol system and that rule-governed system of language. In the next area, in terms of content or the meaning of spoken language, there's a lot that goes into just knowing what those symbols mean. And so we've got a little image here of the word is Halloween. Again, I just took it from the internet. But if you think about Halloween, there's all sorts of other words that are associated with that. So to understand the word Halloween is one thing. So that's what the meaning of the word Halloween is. But then there's all of the meaning-based relationships that are associated with that. What are all of the other words that go together? So, we know that, what are the things that we do on Halloween? What are the things that we wear on Halloween? What are the things that we eat on Halloween? And all of those get connected for us in our mental lexicon, our mental dictionary. And learning to use that symbol system of spoken language means that we have an efficient and effective connected system of word meanings in our mental lexicon. And not only do you have to learn what I call the content words, right? The words like Halloween and treat and candy, but you also have to learn for our language all of the other words that join or connect those words. You have to know the and the and the under and the in and the on. All of those words, you have to know what they mean as well. Then you have to take all those words and you have to figure out how they relate to one another in those longer sentences. So if I have a sentence like the girl went to the store, she wanted to buy flowers, I have to understand from a meaning perspective that the girl in my first sentence matches with the she in the second sentence. Those are different words, those are different symbols, but they mean the same thing and they're connected. And so kids with language, developmental language disorders may have difficulty sort of making those meaning-based associations. She wanted to buy flowers, carnations were her mom's favorite. Well, now I have to know that the word flowers and the word carnations are related to one another. And so the way you understand words, or the way you understand language, is by knowing how those word relationships fit together as well. Then we have words that can mean different things, right? If I said to you, your glasses are dirty, well, that might mean your water glass sitting on the table in front of you is dirty, or it might mean the glasses on your face are dirty. So word meanings can mean different things, and to be able to understand languages, you have to know that there's ambiguity, and then you have to be able to understand that sometimes the words that we use don't actually mean what it appears that they mean. So I used the example before of it's raining cats and dogs outside. Let's all hope that it's not, for lots of different reasons, but we can use language in ways that sound like they mean something, but it really means something else. Then we have the component of use. So how do we use language based on sort of our social context? And I said before, it depends whether I'm talking to my friends at home or my boss at work. There are rules that we're supposed to follow when we're using language socially to interact with other people. There's something called Grice's maxims that talk about we're supposed to use the right amount of language. We have to use enough language, but not too much language. We have to use language that's accurate and that's truthful. We have to use language that's appropriate to our context. And we have to use language that's clear and that sort of fits the situation. So whether I'm using literal or non-literal language depends perhaps on the people that I'm interacting with. If I'm in a room of folks that English is not their first language and I use the expression "it's raining cats and dogs outside," that might be much more alarming to them than it would be to somebody who's an English speaker and has heard that expression many, many times. Then we can take it to a next level, and lots of different things that we can do in those nonverbal ways of using language can be impaired for kids. So the way they use the prosody of their language, the tone, the rate, and the pitch, those things can change the meaning of language. Last night I was talking to my daughter and her boyfriend, and I got distracted, and I was sort of keeping them longer than they wanted to stay, and I said to the boyfriend, "Oh, I'm really sorry." And he said, "Oh, that's okay, it's not like we have reservations or anything." And I thought, oh, I don't know whether that means they do have reservations and I'm keeping them, or whether it means they actually don't. And the tone of his voice influenced the meaning of that language. Turns out they didn't have reservations. It was all good. Nobody was mad. But the point is that language changes based on the context, based on the intonation, based on the people who are using it. Then what we often call, you'll see this word in the field of autism a lot, the hidden curriculum, right? When can you use certain language and when shouldn't you use certain language? If you're a pre-adolescent boy and you're playing in the schoolyard with your friends, it's pretty cool to be swearing while you're out on the play yard with your friends. If you're that boy who's been hauled into the principal's office, it's much less cool to be using swearing with the principal. And so you have to know as a competent language user when is the right time to use language in different ways. Okay. So we've talked about the form, the content, and the use, and sort of how things can go there. And then what we talked about earlier is we can use language to receive information, and we can use language to give information. And so if we think about those form, content, and use components in the receptive domain, so how we receive, if people don't understand words, if they don't understand the sounds that convey meaning, like T and key, big and pig, those sorts of things, they're not going to pull meaning from the language that they hear. If they can't crack that code of grammar and can't pull out sort of how words go together and to understand sentences as they get longer or more complex, they're not going to be able to benefit from the use of language. These are kids who might need more repetitions, they might need more explanations, they might need simpler explanations. And then we also see these are kids who can't take meaning very successfully from language that's long, things like stories, explanations, reasons, that it's just too much information, either in terms of the form, the content, and or the use, to pull all that together. And so their understanding of spoken language can be affected. Similarly, in the expressive domain, if they don't have access to the words, if their mental lexicon is not well organized, if they don't have those grammatical skills to put words together and to combine them so that I can say, the girl went to the store, she bought something, then they're not going to convey themselves very successfully. And I think the little example of Aubrey, who was up there at the beginning, right? She just couldn't find the words. She couldn't put those words together into sentences. Her sentences weren't well connected. And so as a communicator, she was not very effective. Either. And what happens for a lot of the kids that I see is that when they don't have good language skills is that they still have messages to share, but if they don't have that symbol system of language, they find other ways. And often those other ways can be challenging behavior, because behavior is often very effective to get what you want or to get away from what you don't want. And if you don't have a better way to tell people, then you do what you've got. And then socially, again, we've talked about this a little bit, but I think just to emphasize the social impacts of a developmental language disorder is that these are the kids who have difficulty making and maintaining friendships. If they cannot communicate effectively with other people, then they're not sharing their thoughts and ideas. There was an interesting study done that toddlers who show sort of those early risk signs may be more likely to play alone rather than with other kids. If they're playing alone, then they're not getting those skills of playing with other kids and learning how to interact. And so as sort of older children or adolescents, they may be more likely to have social sort of oddities or be more aloof or be more independent. If you can't express your feelings well, again, then we're going to see people expressing things in other way, perhaps with behavior. Kids who have trouble with developmental language issues, that's, like I said before, language is how we do life, right? And so their access to learning, if you think about a kiddo going through school, school is primarily, operated through language. And then if you can't learn well in school, that's going to have implications for people in terms of their job and what they're able to accomplish from a socioeconomic perspective. What we know is that children, adolescents, and adults who have developmental language disorders are actually more likely to be on social assistance, and they are more likely to live at home rather than being able to sort of launch and live independently. And so there's some pretty significant impacts of developmental language disorders sort of on life, if you will. The challenge is, though, that I think developmental language disorders are a really heterogeneous population. So if you think about all the things that we've talked about in terms of the form, the content, the use, the receptive, the expressive, not everything is going to be equally impaired for every child who's got a developmental language disorder. And so for every child, there's going to be a component of figuring out what components of language are easier or harder for these kids, and then matching our interventions or supports accordingly. But it's not sort of a one-size-fits-all. As people who are interacting with a population who are perhaps more likely to encounter kids with developmental language disorders, these are the things that you might see perhaps as red flags for concern. So these are the kids that, quite frankly, their parents are just concerned. Something's not working well for them. Perhaps they're having lots of behavior issues. They're not learning the way that we expect them to. They're not playing with other kids as successfully as we expect them to. Maybe they don't follow the instructions. They don't seem to understand what they're supposed to do or what they're not supposed to do. And they might just be missing the point. They might be kids who are perhaps overly literal, or we call them sort of our black and white kids, and that's because they don't have that flexibility when language gets ambiguous or more conceptual. They're not able to navigate, your glasses are dirty. Well, which version of that glasses word are we talking about? They're kids who can't tell stories, right? Little Aubrey couldn't tell the story of what happened in that book. They can't string their pieces of information together with that sort of cohesion and coherence that would be needed when you have, the girl went to the store, she bought her mother flowers. And so we see these kids who have then a presentation often of behavior concerns, and we do know that developmental language disorders are much more prevalent in a population of kids who have psychiatric concerns. That I think it's between 40 to 50% is one of the stats that I read of kids who have a diagnosed psychiatric issue also have some sort of language impairment. We talked earlier again about these kids having poor social relationships, and then what happens is they're not successful, right? They're not successful socially. They're always getting in trouble. Other kids don't want to play with them. They're not very good at getting themselves out of trouble because they can't talk their way sort of out of it. And so they end up having a weak perception of themselves, right? They tend to think about themselves as being sort of the bad kid, the stupid kid, the kid who can't do what everybody else can. And because language is invisible, right? We talked about that before. They don't know that it's a skill. People don't know that it's a skill. And so they don't have something that they can hang on to as the reason why they're having the difficulties that they're having. They just see surface level, these are the problems that I'm having. But we do know, and I've said this a couple times already, that there is a strong family history of developmental language disorders. And so that might be a red flag for us that we need to be looking more closely for developmental language disorder. So then we get to the point of, okay, well, we wonder if there might be something wrong. Let's do an assessment. And so there's lots of different ways that we can do an assessment. We do an assessment so that we can look at the form, the content, the use of language, the receptive domain of language, the expressive domain of language, because we want to figure out where things are going wrong for kids and then what sorts of supports might be relevant accordingly. And the way that we do that is that we can use standardized tests. That's great. That allows us to compare kids to what we would expect for their developmental age, or for their chronological age, sorry. And we can look at tests. We have tests that look at vocabulary. We have tests that look at grammar. We have, in theory, tests that look at the social use of language, although I always think that's a funny thing that you can't really do a social test of language in a standardized way because that sort of negates the element of social. But we can gather information from language samples, watching kids interact with other people, looking at, Aubrey doing her story retell, and we can gather lots of information from from interviews with people who are interacting with these kids and seeing how they're doing in real life. The catch is, though, in the field of speech-language pathology, we don't actually have a clear cutoff that distinguishes between what we would consider to be a language impairment or developmental language impairment and what we would consider to be just sort of the low end of the average range. And there's been lots of talk about this, and if you read the catalyst studies that I talked about before, they've really said that they don't think that they can identify, if you think about psychology, right, we've got that second percentile, it's very clear, that's our benchmarker. But in language, there's a lot of different things that can be strengths or challenges, right? Form, content, use, all of the things that we've talked about already. And so it makes it really hard to say, well, if a child's vocabulary skills are great, but their grammar skills aren't great, or if their vocabulary and grammar are great, but their social use of language isn't great, where do you kind of draw that line in terms of what's a developmental language disorder? And so one of the things that does make it a little bit difficult is that we don't have that really clear, obvious point that we say, this is the criteria for developmental language disorder. It is more of a clinical sort of qualitative decision about, is communication impaired enough for this child that we would consider it to be a problem, or is it sort of the low end of the average range? We also know, like I talked about before when we had those charts up there about developmental milestones, is that kids develop differently at different ages. And so we do have to account too for a little bit of flexibility in typical language development, and that makes it hard to say, here's the cutoff. And so the other thing is that when we talk about impairments in the use of language, is that a developmental language disorder, or is that maybe something else? We know the kids who have ADHD have a lot of difficulties using language socially. Kids who have autism may have typical sort of vocabulary and grammar skills, but have trouble using language. So the other piece about it is, where do you draw the line in terms of what do you call a developmental language disorder versus what overlaps with something else? And that can be tricky to sort through as well. Nonetheless, if we don't have a clear cutoff, it's still important to recognize that developmental language disorder, I think, is a pretty significant problem for the kids who are affected by it, for all of the reasons that we've talked about already. So the learning difficulties, learning happens in language, and all of those purposes of language that we talked about at the beginning, right? Thinking and reasoning, that as little kids, maybe we do a little bit more by doing, but as kids grow up, we do a lot by thinking and reasoning, and we typically do that through language, whether that's language outside of us or whether that's language sort of in our own minds. And it's how we interact with other people, it's how we understand the nuances of life, it's how we gain our independence, is that we learn the skills to communicate with one another and share information. That leads to employment, that leads to a self-perception of competence, but kids who have developmental language disorder, like I said before, can sound good, and we won't always recognize them. So it is pretty important, I think, for us to be alert that it's possible. Because when we can recognize what a developmental language disorder might look like and the problems that it might present, then we can look at, okay, what are the areas of impairment and what is the severity of the difficulties that this child is having, because then we can tailor our interventions accordingly. And there's lots of different things that we can do to support these kids. So there's lots of environmental accommodations that we can make. It's a lot easier, I think, for any of us to do things that are difficult if there's not a whole lot of stuff going on around us. But for kids who are in a school and who are using language to learn in a classroom that's noisy and other kids are moving around and there's a lot of other things going on and people behind them are talking. So if we can simplify the external environment for these kids, it might allow them to really allocate their resources to the demand of language processing. If we can help them to attend, I always say for our kids with developmental language disorders, it's hard to pay attention to something that you don't understand, right? And I always think if I put myself in a physics class, I probably wouldn't be able to pay attention very long either. But if I can calibrate the language to a level that the kids can use, then their opportunities to attend are going to be better. Their opportunities then to learn are going to be better. So if we can really just match what we're doing to what the kids need, then I think we're enhancing their learning opportunities. We can make modifications to the language that we use. We can make it shorter. We can make it simpler. We can use words that aren't ambiguous. We can use words that are more concrete and more typical of younger communicators than maybe those abstract and conceptual words that might help our kids. We can certainly do therapy for kids. We can help them to build some of those skills in form and content and use, and we can practice those in a therapeutic setting so that then they can hopefully generalize and transfer those skills to their day-to-day interactions. And I think we really want to understand too just sort of the implications of language on learning. So kids who have developmental language disorder, what are their challenges for learning, and then how can we accommodate them perhaps in other ways? Maybe they need to have more hands-on learning opportunities. Maybe they're more visual learners, more kinesthetic learners, rather than language learners of sit in the classroom and I'm going to talk to you and you're going to talk back to me with an answer. So then we've talked lots about developmental language disorder. There's lots of other things we also want to consider when we're thinking about language, and we don't have to talk about these things today, but I just plant them here so that people have them on their radar. is that we've talked about kids who are having trouble learning their first language. Developmental language disorder is about learning that system of language. But there's lots of kids who are exposed to more than one language in this world. The good news is that we know that bilingualism is not something that's going to compound a developmental language disorder. It's not going to add to the burden for these language learners. But what we're going to see is that impairments are going to exist in all of the language that the child knows. And so if their first language is compromised because of a developmental language disorder, then their second language is going to be at least equally compromised. Developmental language disorder, like I said at the beginning, is really about kids who have these language problems without any other known reason for having them. But we also know that kids can have language impairments for lots of other associated reasons. So they can have, language disorder associated with intellectual disability, language disorder associated with traumatic brain injury, language disorder associated with hearing impairment, language disorder associated with autism. So there's lots of other reasons. And I think we have to think about language and the impacts of that for all of those other kids as well. And then, like I said earlier as well, is that we know that kids who have a developmental language disorder are at a much higher risk of problems with literacy. And then there's lots of implications from literacy impairments for academics and occupation and socioeconomic status in life and all of the things that come along with that. So that's a topic for another day, I think. This I just thought was a really nice little graphic because it sort of shows, if you think about that hierarchy that we showed at the beginning in terms of language, language is one part of that giant system of communication. There's lots of ways we can communicate. And I think this also just sort of shows that language is one component of communication. We've talked about how language impairments might affect the communication systems for kids. There's lots of other things that can also affect communication, and we can't sort of not pay attention to them. We're just not paying attention to them now and here. So in summary, I think what we need to take away, or what I hope you will take away, is that developmental language disorder is an invisible but really significant impairment for kids who experience it. And it's really pretty common, affecting about 1 in 14 kids. So if you think about a classroom with 30 kids, that's 2 kids per classroom. That's not insignificant. We know, though, that presentation can be pretty heterogeneous, like we said earlier, and that it's kids who have difficulty in the form, the content, and the use of language, but we don't really know why. There's nothing else that would signal for us that things were a problem. It can change based on how kids are at their developmental, right? It might look like a problem when they're preschoolers. It might be a problem when they're school age or adolescents. But for all of those kids, life happens in language. It's the way we interact with people. It's the way we learn. It's the way we socialize. And if you don't have access to that code because you have an impairment, then life in general is going to be harder. All right, there's lots of different resources here if people are super interested. The Catalyst studies, are great. And Lisa Archibald, who actually is a professor here at Western, does lots of work on language disorders in school-age children, and she would be a great person to Google. There's that use of that word if you wanted to learn more.
Great, thank you very much, Joan.
You're welcome.
Just wondering if you can explain why you can't read doctors' writing.
Well, I think they have their own language. Dr. Nicholson always says speech-language pathologists have our own language. We have our own jargon, but I think doctors kind of have their own too, right? Physicians.
So do we have any questions for Joan? Dr. Nicholson?
Joan, I obviously wholeheartedly agree that, and I think we see all the time that parents and teachers, I think, don't always recognize language disorders and what their impact is on their children. Do you have any suggestions for good reference books for parents and teachers?
Well, somebody probably should write a book someday, but in the meantime, Dr. Archibald is an excellent resource.
It's on the Language and Working Memory Lab webpage?
Yeah.
So when you're talking about developmental language delays, you're talking specifically about spoken language, not and that dyslexia piece is.
Yes, thank you for asking that. Yes. So we know that there's a much higher incidence of kids who have spoken developmental language disorders, language problems, also having written language impairments, but it's not a one-to-one correspondence.
Hi, Joan. Thanks for that great overview. I have actually 2 questions. So the first one is, what would you recommend as the best avenue for diagnosis, given that not everyone has early language delays? It's around age 7. So what's the sort of ideal process for diagnosis? And then my second question is tips for talking to teachers and others who might not see the impairment exactly like you described. People say, oh, they can talk, they're saying everything. well, we know they've got way more to say than what is coming out. So beyond saying that, like, what else is helpful, I think, to explain the impairment?
So I think your assessment, it depends on your child, and that sounds like sort of a fluff answer, but I think some kids can sit down and can do lots of standardized testing, and that will allow us to compare their performance on that protocol with the comparison of a normative sample, and we can look at sort of where they fall. But not everybody can sit down and do standardized testing, and so that's why that slide where we talked about observations and interviews. And so I think you have to use what you've got available to you. And I think that you have to then make a clinical judgment based on the information that you're able to gather from those sources. Ideally, you'll have lots of different sources, right? It's sort of going to be a multimodal assessment that would include more than just one piece of information, the way I think any good clinical work would be done. And then in terms of the teachers, I think maybe where we can advocate for our kids is when we can show them what the kids aren't doing well, right? If that academically they're not sort of performing at the level that we would expect them to do. So even though they're a talker, but there's something that's getting in the way of their learning, or they're not socializing with the other kids as successfully as they might be. The kids who have the behavior problems, well, why do you think he would, be using those actions rather than telling us in a way that would be sort of easier, faster, more socially acceptable, right? Nobody wants to be in trouble. Why do you think he's engaging in these actions that would be causing this type of problem for him? And really maybe just helping to highlight what they see but don't recognize that they see.
Goldberg.
You mentioned alternative learning approaches. Are there still quacks pushing facilitated communication?
So no to that. However, now that technology is like super duper available and cheap and anybody can download an app, ProLoco to Go is sort of like my new facilitated communication that everybody just believes if you give a child ProLoco to Go, they're going to be okay. And that can be a whole other talk. But so no to facilitated communication, but yes to lots of other stuff that's not necessarily a match.
Okay, and we had another one over here.
Thank you, Joan, for the nice overview. I just wanted, if you had any thoughts about learning more than one language, bilingualism, and the impact on improving the development, like any connection between learning more than one language and development?
So what the research about bilingualism tells us is that one language, if you have a developmental language impairment, it's going to be at the level that it's at. If you're adding another language, it's going to be at sort of the same level. So I don't know that it enhances language development, and I don't think that it impairs language development. I think what we just see is that a child who has a capacity for language will apply that capacity, whether it's English, whether it's Urdu, whether it's Latin, whether it's sign language. They're going to sort of reach that same level of ability regardless of the language. So I don't think it helps, I don't think it hurts. I think it just is. However, that being said, sorry, one more thing, is that what we do say to parents is speak to your child in the language that is most comfortable for you, right, as the parent, as the educator, because I think that's where you're going to be able to role model the best language. And so we do talk about that component of dual learning, yeah, right? If I have a parent who speaks Spanish at home, and that's really the first language, and they try to use English, but it's really broken, but they're using English because they've moved to a place in Canada that uses English, but that's not the best role model of language for their child. Use the language that you can role model for your child.
Okay, great. Well, thank you.